as they are mentioned in some of the guidelines. So both opiates and nicotide are not recommended in the guidelines at this point in time. So of course, loop diuretics are our next go-to, and particularly in those patients that are fluid overloaded. For a while, diuretics fell out of favor a bit because they're not as good a venodilator as nitroglycerin. But recently, Matsui et al. Did a study showing that the mortality in patients was reduced substantially from 2.3% from 6% to 2.3% in patients that received diuretics within 6 hours. Now that seems like a long time, but the quicker that they get their loop diuretics in, the better the outcome is for them. So the initial dose would be furosemide, 40 milligrams IV, which would be repeated, and then torsemide or bumetanide are two other options. Of course, this dose would be increased if the patients were already on a loop diuretic or if they have renal failure. So the use of inotropes or vasopressors is reserved only for those patients in that category with hypoperfusion, so those patients with shock. And so firstly, the type with a reduced ejection fraction, an inotrope would be the go-to with dobutamine, the beta agonist, as the inotrope of choice at 0.5 to 1 micrograms per kilogram per minute. Milrinone is mentioned as another one. There's a typo in there. And then these are used as a temporizing measure until mechanical support is made available or some other alternative. So it's not supposed to be long-term therapy. So if the patient is known to have a preserved ejection fraction, you might want to even consider small crystalloid boluses if there is no evidence of fluid overload to try and increase, prime the pump to increase the stroke volume. And then IV vasopressors, particularly norepinephrine, 8 to 12 mics per minute, or phenylephrine would be indicated. And again, temporizing measure followed quickly by an echocardiogram to assess in more detail what's going on with the heart. So in most cases, we don't know what the ejection fraction is, and so in those cases, an inotrope plus or minus a vasodilator, depending on the clinical situation, would be indicated. And at the same time, assessing the need for mechanical support and obtain immediate echo. Those with hypoperfusion, also you would want to be considering whether the renal failure may be the cause. And sometimes we get renal failure patients that come in with heart failure. So dialysis is the go-to, of course, for those patients. Blood transfusion may be necessary if anemia is a significant factor. Rate and rhythm control is important in some cases, unless it's, of course, a compensatory tachycardia that's trying to normalize the patient's physiology. So the pros and cons of rate control have to be carefully considered. And, of course, coronary revascularization if it's a ST elevation MI. So for those unfortunate few who have refractory acute decompensated heart failure, the real big guns would be last in consideration. So for failure of oxygenation, we would think about ECMO. And for persistent shock, we would consider intra-aortic balloon counterpulsation. And there's a couple of nice studies that describe their use in the situation of shock, which I have referenced here. And again, as I mentioned, all of the precipitating factors need to be considered and treated. A lot of them, hypertension, sepsis, renal failure, drugs, things like acute aortic or mitral insufficiency could be seen on an echo and hopefully on clinical exam if you're good at your murmurs, and aortic dissection in the right clinical situation. Of course, those things would need urgent cardiac surgery consultation. So then our next, once we've got this patient treated, then our next, or last thing that the emergency physician needs to consider is what to do with the patient. So are they safe to be discharged, or do they need to be hospitalized? And of course, that's not going to be evident an hour or two after they present. Generally, they need a period of time in our observation unit, if we're lucky enough to have one, and determine after 12 to 24 hours if they're able to go home or not. And also to identify this group of higher-risk patients who may benefit from CCU admission. So Lai and al. Did a study in 2016 which showed a group of patients in Canada versus the United States. The Canadian were in Ottawa, and the US center was in the Mayo Clinic in Rochester. And the admission rate in the Mayo Clinic was 95%, in Canada was 50%, yet the outcomes were similar. So outcomes were, like the adverse outcomes were relapse to the emergency department, myocardial infarctions, and death within 30 days. So these findings really question the need for admission of patients with heart failure. So just recently, 2016, the European Society of Cardiology did a paper on safe discharge of acute heart failure patients from the emergency department. And this group referenced a couple of Canadian studies, really the only evidence-based information that's out there. So the first is the heart failure risk score that was developed by my colleague, Dr. Ian Steele in Ottawa. And so this group wanted to identify a risk scoring system to identify which patients were at high risk for serious adverse events. And they came up with a number of items with a score of 0 to 15 that could predict which patients would be at higher risk if they were discharged. So they found out that if they had 0 of these factors with 95% sensitivity, they would not end up with an adverse event. So these people, they felt were safe to go home. If they had a score of 2, there was 81% likely that they wouldn't have an adverse event, or if they had 2, it was 65%. So then a decision would have to be made on the level of risk that would be acceptable to tolerate for discharge. And the reason why discharge is so important is because of the cost of hospital admission and the burden on the entire healthcare system. So then another group, Doug Lee and al., did another study to try and predict the mortality of heart failure in emergent care. Whoops, sorry. And they looked at absolute 7-day mortality rates and with 95% confidence intervals by something called the EMERGE score, so EHMRG. And there's a couple of graphs. So this is basically the factors for the EMERGE score, Emergency Heart Failure Mortality Risk Guide. And there's a really nice calculator online that you can use, and the link to it is here, where you can input all of these factors about your patient and get the risk of mortality online. And I mean, it's not perfect. It's something to use in conjunction with clinical judgment, but it's something that is ongoing work on this. So basically, if there was 1 to 3 of these factors, the mortality was 0.3%. If there was 4 to 7, it was 3.5, and 8 to 10 is 8.2. So then Raslin, Brown, and al. did a study on hemodynamically stable acute heart failure patients requiring a critical care unit admission. So basically, they wondered which patients needed to go to an ICU or a CCU. So these are some of the factors that they found, and I'm not going to go through it in detail. I think all of these presentations are going to be posted if you would like to look it up. But essentially, this is the receiver operating curve for their tool for the baseline in their refined clinical prediction models for their data. And so the refined one used BMP as another factor in determining which patients needed ICU admission. And they found that a very small number of patients actually needed to be admitted to a critical care unit. So in conclusion, acute heart failure syndromes are common, and emergency physicians are key to reducing morbidity and mortality. Early diagnosis and rapid management are key. Oxygenation by escalating measures are loop diuretics for volume overload patients and vasodilators for hypertensive patients, and correcting of precipitating factors are the mainstay of our treatment in the emergency department. And evidence for risk stratification is ongoing toward the development of decision tools to determine patient disposition. So thanks very much for your attention, and I'm happy to answer any questions.
Does anybody have any questions for Dr. McEwen? Sorry. Thank you very much for that wonderful presentation.
So now it's my pleasure and honor to invite Mustafa Sabak to the stage. He will give us a talk about what's new in the COPD guidelines. And I worked really hard to find something in the internet about him, and I found some very interesting thing. On his Twitter account, he presents himself as emergency physician, brain drain, and forever student. So welcome on the stage, Mustafa Sabak.
Thank you so much. Hi everyone, I'm honored to be here and to be joining this distinguished group of participants and speakers. My name is Mustafa Sabak, and I'm an emergency physician in Nizip at Nizip State Hospital, close to the Syrian border, east of Turkey. And I'm very happy to be here today to talk about recent updates in COPD. I have no financial disclosure to report it. The objective is to discuss the new recommendations of the GOLD 2019 GOLD report. This is the shortly called Global Initiative for Chronic Obstructive Lung Disease. This report therapeutic strategy and particularly its impact on diagnosis, management, and assessment of COPD. And this is the current guideline about COPD, which is published in this year, and revision of the GOLD 2017, and has been reported literature in COPD research and case that was published from 2017 and 2018. As you know, it is common and represents an important public health challenge, and that is both preventable and treatable disease, and characterized by persistent respiratory symptoms and airflow limitation that is due to airway and alveolar abnormalities usually caused by a significant exposure to noxious gas and particles. And the most common symptoms, dyspnea, cough, and sputum production. COPD may be punctuated by periods of acute worsening of respiratory symptoms, which is called exacerbations. In most patients, COPD is associated with significant concomitant chronic diseases, which increases its morbidity and mortality. As you know, the chronic airflow limitation is caused by a mixture of small airway diseases and parenchymal destruction. The relative contribution of which vary from person to person. These changes do not always occur together, but evolve at different rates over time. And global prevalence roughly 12%, and it's appreciably higher in smokers and ex-smokers compared to non-smokers, and higher in those more than 40 years of age, and higher in men and compared to women. But more recent data from developed countries has reported that the prevalence of COPD is now almost equal in men and women. This is a burden problem because major cause of chronic morbidity mortality throughout the world, and that induce an economic and social burden. Currently, fourth leading cause of death in the world, and more than 3 million people died of COPD in 2012, accounting for 6% of all deaths globally. And the other important thing, disability-adjusted life of year, which is called DALY, for a specific condition are the sum of year lost because of premature mortality and years of life lived with disability. And the other problem is COPD may force at least two individuals to leave workplace, the affected individual and the family member who must stay at home to care their stable relative. Most national data shows that less than 6% of the adult population have been told that they have COPD. Roughly 15 million Americans are underdiagnosed. So there has to be a national action plan to create awareness. I don't know how many Turkish people are underdiagnosed, but unfortunately there is a cigarette culture in here. And if you are in depressed, someone can offer to light up a cigarette. The main risk factor, tobacco smoking, environmental exposure such as BMS, indoor or outdoor pollution, and besides exposures, host factors predispose individuals to develop COPD. For heavy smokers, fewer than 50% develop COPD during lifetime. So lots of different factors such as genetic, age, gender, and that there is a growing evidence that indoor biomass exposure, specifically for the women, that may predispose women to develop COPD. In many developing countries, poverty and low socio-economic status are associated with an increased risk of development COPD. And the other thing, for the infection, HIV patients are at risk of COPD. And it should be considered in many patients who has dyspnea, chronic cough, and sputum production. If there is a history of exposure to risk factors such as smoking, pollution, as I mentioned about early, host factors, family history, because multiple K indicators increases the probability of diagnosis of COPD, and spirometry is required to make the diagnosis. How it works, the presence of post-bronchodilator FEV1, FVC ratio less than 0 point confirms the presence of persistent airflow limitation. And after diagnosis, why do we need to assess COPD? That's because to determine the level of airflow limitation, the impact of disease on the patient's health status, the risk of future events, and in order to guide the therapy. In the presence of the low FEV1, FVC, the percent of predicted FEV1 is used to determine the severity of airflow limitation, but there is only a weak correlation between FEV1 symptoms and impairment of patient's health status. For this reason, formal symptomatic assessment is required, and there are different types of assessment tools, but CAT and MMRC are most widely used among these. The CAT is short, brief, simple questionnaire for assessing and monitoring COPD. It is an 8-item unidimensional measure of patient's health status impairment in COPD. And MMRC is a simple measurement of breathlessness and relates well to other measures of health status and predicts future mortality risk. However, it is now recognized that COPD impacts beyond just dyspnea. For this reason, a comprehensive assessment of symptoms is recommended rather than just a measure of breathlessness. Exacerbation are defined as acute worsening of respiratory symptoms that results in additional therapy. These events are classified in three groups: mild, moderate, and severe. But the different things, blood eosinophil count may also predict exacerbation rate for the future. But the best predictor of having frequent exacerbation is a history of earlier treated events. FEV1 by itself lack of sufficient precision. We all know the COPD is systemic disorder. Patients with COPD often have important concomitant chronic illnesses at the time of diagnosis. But the presence of comorbidities should not alter COPD treatment and management. Comorbidities should be treated by usual standard regardless of the presence of COPD. And lung cancer is frequently seen, and a main cause of that. Cardiovascular diseases are common and important. There are lots of different kinds of diseases, but osteoporosis, anxiety, and depression we can see. Therefore, comorbidities should be looked for routinely and treated appropriately in any patient with COPD. In the revised assessment scheme, patients should undergo spirometry to determine the severity of airflow limitation, and then they should also undergo assessment of either dyspnea using MMRC or CAT. Finally, their history of moderate severe exacerbation should be recorded. If we give an example, consider two patients, both patients with FEV1 less than 30%, which is group GOLD 4, both with CAT score of 18, but one with 0 exacerbation in the past year, the other one 3 exacerbation in the past year. The subject with 3 exacerbation in the past year would be grade 4. The other patient would be classified as group B. This is important. Furthermore, in some circumstances, such as urgent presentation to emergency department, the ability to assess patients based on symptoms and exacerbation history independent of spirometry value, because lots of emergency departments don't have spirometry. This is important for us. Allows clinicians to initiate a treatment plan based on revised ABCD scheme alone. If we look at the clinical course, during exacerbation, the peripheral airway limitation progressively traps gas during expiration, resulting in hyperinflation and leads to increased dyspnea and limitation of exercise capacity and disconditioning. As a result, the patient's quality of life is affected because of these reasons. I would like to talk about the treatment models that is suggested by the guideline. Smoking cessation is a key. The effectiveness and safety of e-cigarettes is very common, but it's not uncertain at present. Inhaler technique needs to be assessed regularly. Vaccination is really important, especially influenza and pneumococcal vaccination decreases lower respiratory tract infections. Pulmonary rehabilitation, we don't know enough information about that, but improves symptoms and quality of life. Usually pulmonologists care about that. In patients with severe resting chronic hypoxemia, long-term oxygen therapy improves the life, survive. And patients with severe chronic hypercapnia and history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may decrease mortality. And in selected patients with advanced emphysema refractory to the optimized therapy, surgical interventions can be considered. Palliative approach is effective for the symptoms. If we look at the pharmacology therapy, we aim to reduce symptoms and frequency, severity of exacerbations, but at the same time improve health status and exercise tolerance. But each treatment regime needs to be individualized as the relation between severity of symptoms and airflow limitation. The choice within each class depends on availability and cost of medication and favorable clinical response balanced against side effects. This shows you the current therapy that we have pharmacologically. Beta-2 agonists and anticholinergic, which are bronchodilators, short-acting and long-acting. methylxanthines, double combination and triple combination, and the phosphodiesterase 4 inhibitors, which is anti-inflammatory drug, mucolytic agents. Bronchodilators, especially they recommended long-acting beta agonist and long-acting antimuscarinic agents are preferred over short-acting agents, except for patients with only occasional dyspnea. Inhaled bronchodilators are recommended over oral bronchodilators because some of the physicians usually use oral bronchodilators. Specifically in our department, some of the pediatrics use it for the kids. Theophylline is not recommended because of the side effects. Long-term monotherapy with inhaled corticosteroids not recommended, but if a patient with long-acting beta-2 agonist for patients with a history of exacerbations, you can use it inhaled corticosteroids. Long-term therapy with oral corticosteroid is not recommended. In former smokers with exacerbation, despite appropriate therapy, macrolides, specifically azithromycin, can be considered. Statin therapy is not recommended. Antioxidant mucolyt are recommended only in selected patients. Antitussive cannot be recommended, and low-dose, long-acting oral or parenteral opioids we can't prescribe in the emergency room. So maybe consider it for improve the patient's breathlessness. This chart is very important because we can decide initial therapy for this ABCD assessment tool. If the patient in group A should be offered bronchodilator treatments based on its effect on breathlessness. For B group, initial therapy should consist of long-term acting bronchodilators. In group C, long-acting anti-muscarinic agent was superior to long-acting beta-2 agonist regarding exacerbation prevention. In group D, long-acting agents as initial treatment should be guided by level of symptoms. You know, some of COPD patients are particularly susceptible of frequent exacerbations, and these patients have been shown to have worse health status and morbidity. The exact reason for an individual's increased susceptibility to exacerbations symptoms remains largely unknown, but the strongest predictor is the number of exacerbations they have had in prior years. Most common reason triggered by respiratory viral infection, which is rhinovirus, although bacterial infection and environmental factors such as pollution can affect patients. The goal to minimize the negative impact of the current exacerbation and to prevent subsequent events. When the patient with exacerbation comes to ER, they should be provided by supplementing oxygen, and we can decide this is life-threatening condition or not. Do patients need invasive ventilation or not? So if so, healthcare providers should consider admission to the respiratory or intensive care units of the hospital. First of all, we have to support respiratory. First of all, oxygen therapy is a key component of hospital treatment of an exacerbation. We can use oxygen by ventral mask or high-flow oxygen therapy by nasal cannula, but high-flow oxygen cannula reduce the need of intubation and mortality, hypercapnia, but still there is a need for well-designed randomized multi-center trial to study for its effect. If the patient has a persistent respiratory alstosis and hypoxemia and severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breath, we should consider non-invasive mechanical ventilation. When do we need the weaning from non-invasive ventilation? If the patient's clinical status improves and tolerate at least 4 hours of unassisted breathing, then can be directly discontinued without any need for weaning period. This is the for need to intubation, invasive mechanic ventilation. If the patient unable to tolerate non-invasive ventilation or non-invasive ventilation failure, and the patient in status post-cardiac arrest, diminished consciousness, and there is a risk factor of massive aspiration, and there's a severe life-threatening arrhythmias, and life-threatening hypoxemia in patients unable to tolerate non-invasive ventilation, then you can concern about the invasive mechanic ventilation. How to manage of exacerbation with pharmacotherapy? As you know, bronchodilators, corticosteroid, and antibiotics are most commonly used for exacerbation. Short-acting inhaled beta-2 agonists with short-acting anticholinergic or not are recommended as initial bronchodilators to treat the exacerbation. Maintenance therapy with LABA is important. Specifically, should be initiated as soon as possible before hospital discharge. Systemic corticosteroids can improve lung function, oxygenation, and shorten recovery time and hospitalization duration, but should be 40 milligram per day and during 5 days. The use of antibiotics in exacerbation remains controversial, but if the patient's symptoms increase in dyspnea, sputum volume, and sputum purulence, then you're concerned about antibiotics. There is no clear evidence to guide CRP and procalcitonin for the ER, so we can decide for the patient's clinical status. Methylxanthines are not recommended due to increased side effects. Non-invasive mechanic ventilation is very important because it improves gas exchange, reduce work of breathing, and the need for intubation, decrease hospitalization during, and improve survive. Some of the factors that impact the patient's outcome: if the patient's older age and lower body mass index, previous hospitalization for exacerbation, and after discharge need for long-term oxygen therapy, that means patient's mortality is high. The problem is not only exacerbation. Frequent exacerbation is very important than the only one exacerbation because it's effective the disease progression. The patients decrease quality of life and increase inflammation, faster disease progression, increase hospitalization, and the risk of recurrent exacerbation and increased mortality rate. So we need to decrease frequent exacerbation, that's why. The intervention is important to reduce the frequency of it. Those are bronchodilators, corticosteroid-containing regimes, double and triple regimes, anti-inflammatory drugs, anti-infectives such as vaccinations and long-term macrolides for the smokers, regulators, and smoking cessation program, rehabilitation, and some surgical procedures. Depending on severity on exacerbation and the severity of underlying disease, an exacerbation can be managed either the outpatient or inpatient setting. More than 80% of exacerbation are managed on outpatient basis with pharmacological therapies, including bronchodilators, corticosteroid, and antibiotics, but local resources need to be considered for that. This is the indications for the ICU admission. If the patient has severe dyspnea that responds inadequately to initial emergency therapy, patients change in mental status such as confusion and coma, persistence of worsening hypoxemia, respiratory acidosis, and despite the supplemental oxygen and non-invasive mechanic ventilation, hemodynamic instability and the patient need for vasopressor and fluids, patients need to immediate admission to the intensive care unit. And at the same time, local resources need to be considered for that. The cause, severity, impact, treatment, and time of course of exacerbations varies from patient to patient, and facilities in the community and the healthcare system differ from country. Accordingly, there are no standards that can be applied to timing and nature of the discharge. These measures all seem sensible. There is insufficient data that they influence either readmission rates or short-term or mortality, and there is little evidence of cost-effectiveness. But early follow-up following discharge should be undertaken when possible and has been related to less exacerbation-related readmissions. Thanks so much.
Thank you very much indeed, Mr. Dr. Sabak, for your impressive presentation. So I think we all have a good overview now. And are there any questions in the auditorium? Yes, please. Bejek.
Thank you very much, Dr. Mustafa, for your talk. I'm sorry, while you were preparing for your presentation, did you read anything in paper about the dilatation of the tracheal tract or using of stent for the patient who have really tracheal constriction?
Tracheal construction?
Tracheal, stent, using stent to tracheal tract.
Oh, I didn't read anything about that on the guideline. I'm sorry about that.
Thank you.
Yeah.
Yes, there's another question here over there.
Mr. Sabak, thank you for your presentation. I want to ask you, do you know anything or do you talk about any scoring system that can standardize the determination of the outcome of the patients who presented to ED with COPD exacerbation like PCI and pneumonia?
For pneumonia?
No. For COPD exacerbation, a scoring system that, according to that, we can determine the outcome,
there is no
admittance or discharge of the patient.
I didn't read anything about scoring system, but the important thing to deciding the antibiotics for the pneumonia, for the exacerbation, we should decide for the clinical status, such as increased dyspnea and coughing and sputum production. It doesn't work any CRP or procalcitonin, just only need to determine the patient's status.
Okay, thank you.
There's no any scoring system.
Thanks a lot.
I didn't read it, I'm sorry about that. Yeah. That's it.
I have one more question for you.
Please.
In the United States, this is one of the top 5 causes of hospital readmission within 30 days. Do you track hospital readmissions for people discharged with COPD in Turkey?
Yeah, we can discharge because the local resources is not enough. And most of the time we decided by laboratory results and the patient status. Some of them are not good enough for the discharge, but try to keep them care. I'm really sorry, but we don't have enough opportunity to admit hospital or ICU. Yeah, unfortunately.
So thank you very much, Dr. Sabak, and we would give you a big applause again.
Thank you. Thanks so much.
Now we are looking forward to the presentation about traditional Chinese medicine from Professor Wang Zong. He will be kindly replaced by Professor Mai Chi, Vice President of the Chinese International Exchange and Promotion Association for Medical and Healthcare of Emergency Medicine. So welcome, Professor Mai Chi.
So, dear Chairman, ladies and gentlemen, I'm Dr. Wei Jie from China. I'm also an emergency physician. On the behalf of my President, Dr. Wang Zong, now he's sitting downstairs, so later maybe you can ask a question for him. And I'm going to speak up of something about Chinese traditional medicine, which we call TCM. And first of all, I would like to say thanks for President Basa Canlı's invitation, we come here. And also, I would like to say sorry for last year situation. According to some reason, we failed to come. Anyway, this time we are here in this room together with all of you. And my topic is about traditional Chinese medicine. But speaking about traditional Chinese medicine is really a huge project. For me, I don't have enough time to explain everything in details. So I will try my best to give all of you a very brief introduction about TCM. Okay, here you can see this is the map of China, and this star. The star is Beijing, and Beijing is the heart of China's capital, and another star is my city. My city is just in the middle of China. It called Wuhan. Okay, this picture is showed Wuhan, the view. You can see the river go across the city. The river is the Yangtze River is the longest one in China and one of the longest all of the world. And the bridge go across the river. The bridge we have in the city, we have over 10 bridges go across the river. So the river called the bridge river or the river city. And the building is yellow-green tower. That's the symbol of the city. If you see the three parts together, the river, bridge, and the building, the tower, you will be in Wuhan. So welcome in Wuhan. This is my university, Wuhan University. People say the campus of the university is the most beautiful China. I really appreciated of this. Here you can see this is my hospital. My hospital has 2 branches together, and this one is the largest one. I work over here. My ER is just in the first building, and I do have a general ICU in another building. I'm in charge of ER and also general ICU in my department, in my hospital. Okay, what's traditional Chinese medicine? Here we have a sentence. The sentence from a traditional Chinese medicine textbook in China. It says, the system, TCM system, based on Chinese medicine theory and clinical practice experience. The system study human health and life activities and disease transformation. Then to do prevention and to do diagnosis, to practice treatment, even rehabilitated and multi-health care. Okay, this is the concept. The concept is a little more abstract even for me, so we need something more in details. Yes, TCM has long time history. More than 2,000 years ago came out Huangdi, classic medicine. Huangdi is the name of ancient traditional Chinese physician. He did his practice and also wrote some medical books. It gives complete and systemic exposition to the subject not following. The relationship between human and natural, that's important. Human physiology and pathology, the diagnosis, treatment, and prevention of the disease. It also uses its own theories that very important for the system of yin and yang. You all know yin and yang, I know. And 5 elements system to deal with the principle of treatment, which we call the TDS, and according to the climate and seasonal conditions, even geographic location and individual constitution. Taking the human body as an organ whole and taking the human body with the surroundings and the environment as well. Okay, TCM has its own theories. We can see some. The red parts of the theory is we often use even now in China. So I just try my best to explain, even this is not so easy for me because I'm not a TCM physician. So first of all, yin and yang. So yin and yang theory permeates all aspects of the theoretical system of TCM. The theory is used to explain the organ structure, physiological function, and pathological changes of the human body. It also serves as a principle of a guide clinic diagnosis. For example, every organ, the whole body and every organ has two parts, yin and yang, to balance. When yin and yang get balanced together, everything, the function of the body could be normal and stable. For example, according to the system of cardiovascular system, and if yin is less, yang is too much. So hypertension comes from. On the other hand, in some situation, for example, infection or sepsis, the yin is very, very strong. That means the blood pressure could be very low, maybe shock comes out. So we need to give some medicines or some other methods to treat patient to get the two parts to be balanced together and to make the function to be normal. So this is the yin and yang. Also the 5 elements theory. This is a little more difficult for me to explain in English language. According to the theory, the traditional theory, they have elements referred to wood, fire, earth, mental, water, and their motions together. So the theory results from ancient Chinese observation and study during their lives and working together, since the 5 elements are basic substance to constitute the universe. So they are also indispensable for life as well. Why not? So the third theory is about acupuncture. You all know acupuncture. This is the therapy for TCM, but the therapy has the basic idea that is meridians. When we're doing acupuncture, we need to find the point. We cute acupoint. We put the acupoint to get some result by using this method. When we linked every point together, that is meridians. So this is a meridian map. In China, if you go to office of TCM physician, you can see everywhere this map. The TCM, in the past, the physician wrote some books and to explain something, even some basic idea. For example, 黄帝内经, this one is the oldest one. So refer these old books to the modern theory. They could be this. Autonomy and this, even difficult cases sharing. So we can contact everything happened in the past and with the modern society system right here. And also, this is a philosophy of traditional Chinese medicine. There are 3 sentences now is common used even outside of China. It says, 上医医未病治病. That means if you are the doctor, but in the top level, you can treat a patient who is not really sick. So that means you can hold back the sick happen. So you are very clever. That means you need a smart mind, you need sharp vision, you need very good experience in the past. So that's the top level doctors. But if you are a doctor, but in the middle never, you treat the patient who is going to sick, you cannot hold the program back, but you can get ready, waiting for the program. The last one, the third never of doctor only treat patient who has already get sick. So this is our philosophy. I do think it is very useful for the modern system, for the young doctors to do something. Okay, we have the theory, and then how do we do? Just follow the theory. How do you do when you doing medical practice diagnosis first? Yes, TCM. We also need to make the diagnosis first. How do we do? We just follow the four steps sequence to do diagnosis. First is one. One means to look. To do, not just look, to realize something by looking. So that's observation. The second is when. When means to listen, to listen and to smell. And by listening and smell, you realize something. And the third one is a question to make the history of the program and to know the cause and the reason. And finally, that's very important, very useful, very unique in the TCM, just by touch the puzzle to realize something, and finally make the diagnosis. This is the need very serious training. Even I couldn't do this. And after the diagnosis, we have to do the treatment, of course. We have three parts to do traditional Chinese medicine treatment. First of all is physical therapy. The second, by using some medicine. And third one is traditional Chinese medicine, surgical. And I just want to explain the two parts of this, because I really don't know the theory and practice of surgical department. Surgical part of this system. So the therapy, the physical therapy, we have a lot of ways: acupuncture and moxibustion. And this is the whole one, and fire cupping, massage, and scraping. The last one now is very, we use very little time, just in the countryside, home care. So here we can have a picture of acupuncture. So acupuncture just put the needle in the acu point and remain for some time. Sometimes we twist the end of the needle. If we use we smell the end of the needle with the herbal stick. That is moist position, and this. File capping, some countryside clinical house, they use this. And this massage, massage right here, they can relieve some pain, acute pain, get the muscle to be relaxed, something like this. Also, here, another way to do treatment is by using Chinese traditional medicine. Here you can see that the top one, the picture is a traditional pharmacy. So we keep every medicine, every Chinese traditional medicine in the single boxes. And this one is a typical Chinese prescription by physician writing. So the patient hold this prescription to the pharmacy, and the staff will, according to this prescription, to choose the medicine and to weight how much and make them together to be mixed one. So here you can see this is the medicine. This is how much. This is the medicine, how much, medicine, how much. So they choose everyone together to make a mixed one to put this medicine Sorry, is there anyone can help me to move the slides? Some problem. Put the medicine into a container, add some water to boil it for hours, and then the medical soap we called decoction comes out. And take certain dose of the soap 1 or 2 times a day. That's normal treat. That's normal treat. Okay. Okay, I can now move it, please. Okay, this is a decoction. Take it 1 or 2 times a day. So now in the past, we do use this kind of ways to deal with this type of problem. For example, emergency pain, conversion, even fever. The paper is published in a Chinese traditional magazine, traditional medicine magazine. It says to stop asthma by using acupuncture around the ear. So that's very, very useful. But now, we are doing modern medicine. So what we are doing now, this is the idea of our mind. TCM is a part of Chinese culture. General medicine education also involves in TCM. For example, when I was a medical student in the college, I took about 60 in China, 60 hours to study traditional Chinese medicine, even to play Tai Chi, because they do believe that Tai Chi could make persons to be inner pins together. Many people trust only TCM in the country, for example, especially in the countryside. And almost every city has a TCM hospital. My city has 2, and almost every general hospital has a TCM department. My hospital has 1. In China, we have 16 Chinese medicine university. So in Beijing, Chengdu, the city, the last one is my region. In my region, we have what this picture shows the greeting from Beijing Chinese Medicine University. So this is the principle. When we use the Chinese medicine, this is the principle. Just combine Chinese and the Western medicine together, first of all, and deal with the emergency syndrome first, and then with the basic course later. This is the philosophy for us as me as well. Get instant result and step by step. And 立竿见影, 立竿见影, it's a Chinese idiom. It goes when you put a bamboo stick under the sun, under the sunshine, you will get the shadow immediately. So that means if the situation of the patient is more serious, so you need to make the situation to be stable immediately. So you need to use maybe Western medicine, not just the Chinese one. Okay, these are some mental prescription. Even now we are using in ER or ED. The red one is we are often used. So especially the sinful injection, yes, in China, we have some manufacturers, some pharmacy manufacturers, they do make the medicine to be an injection. This one is a famous one and common use in emergency department. Of course, TCM physicians, they do some research. There are fundamental researches published outside of China. The last one is a clinical research. So, and Sinful 注射液 also the sinful injection also has this multi-center clinical study. They just want to treat heart failure using when doing CPR, also using in the shock patient ACS, even in MI. So they are doing, and we are waiting for. Of course, the system has some questions as well, just like modern medicine. Yeah, we also have some questions, some programs as well. The security, effective, even quality control, they are very normal. And this one, this is the conclusion of my speech. TCM is a great treasure. Of course, it's a treasure of China. The biggest characteristic of TCM is regarding the human body itself as an organ whole. It was developing and organizing for us, not just now, but future. There still leave over some questions that cannot be fully explained among the field. Even the system is really effective when using. What we need to do in the future is finding the basic of TCM in different ways and different aspects. Due to some historical reason, TCM really has its own limitation. We should prove the good, the safe, and effective aspect of TCM with the aid of modern research platform and remove its risks, taking its essence. Take the advantage of it. And combine, this is what I wrote, combine Chinese traditional medicine and Western medicine together may be the best way to make TCM to be moderation. Okay, that's my speech. Thanks for.
Do we have any questions for Dr. Wenshi? Quite a few questions.
Really, thank you very much for your interesting talk, Dr. Wei. I have a few questions, possible? Not just one, okay? First, your university is already an historical, it is a world historical university. I am wondering are you doing this training as professional? I mean, is it possible to getting this job by PhD program, by doctorate program in China? And does your community obey this traditional treatment? And is it possible? Are you giving this traditional therapy to your medical faculty as lectures? Do we do it? And does China accept a patient from outside the China for this treatment? And is it paid by the government, by the health system, while we are writing on prescription? Thank you very much.
Oh, okay. I catch your meaning. So you ask if the student go to the traditional Chinese university, they will pay or the government pay for them. Yeah, they pay by themselves. Of course, this is common use. It's a common the education system. It's not a special one. And also in the college, they have degree courses. Even in some, not all, in some, they have PhD. We have a lot of students go over outside of China. For example, Germany, something like this.
Another question over there, please. This gentleman.
Hi there, my name is Dr. Alwi. I'm from Malaysia. My question is, in Malaysia we have a lot of traditional Chinese medicine and it's a lot of followers. I just like to ask this question. In China, when you do kidney transplant, is there a role of Chinese medicine management as part of recovery process? Thank you.
Sorry. Your question is to be a TCM physician, you need to get a license, right?
My question is there a role in a recovery process after a kidney transplant and the role of Chinese medicine application?
Yeah, not
Okay.
just one can. For me, I cannot write this prescription. Only TCM physician, they can write, they can make it. Only them. Yes, it's not rule, but principle.
Is there another question here in the front?
I am an acupuncture practitioner here in Turkey, and also I am an emergency physician. And I do in my practice in emergency acupuncture therapies too. But
Really?
I want to ask you, how do your practice in a real emergency case? Also, when a case needs an operation, do you give them an emergency traditional medicine or the acupuncture too behind the other process, or give you this patient only to the surgeons?
Go back 20 years ago, we did in this way. At that time, I'm very young, but now we never. In the past, we had, actually, but now we don't have, because the modern medicine is very effective, more quickly. Thanks for the question.
I think we'll move the questions to the end. I know Dr. Kandar, did you want to say something? Okay, thank you very much. And I thought we'd have a presentation here, please.
Okay. Sorry, we try for this time 2 years. We waiting for you 2 years. I want to give something from Turkey because you couldn't come last night. And
So sorry.
President Wang Zong, please. Wang Zong? Okay, thank you.
Thank you, everybody. I know there's going to be a short break here, and they'll come back in about 10 minutes for another set of presentations. Thank you again, everyone. You've been a great audience, and thank you again for our wonderful speakers.
The environment, and even in case of terrorist attack. You have to be aware that air pollution is unfortunately a serious worldwide issue resulting in inhalation intoxications, and the 5 major pollutants are carbon monoxide, sulfur dioxide, nitrogen dioxide, particulate matters, and ozone. The air we breathe always contains different particles, droplets, and gases, sometimes from natural sources and sometimes from man-made sources. One important concern is that toxicity will be related for particles with their size. And you see here clearly on this slide that the largest particles will mainly result in toxicity in the upper airways, while the smallest particles in toxicity in the alveoli. And of course, with gases, it will be possible to reach the alveoli and to result in local but also systemic toxicity. Daily at the workplace, there are several industrial toxicants that may produce respiratory disease, either acute but also chronic. One important issue is to prevent and control these possible toxicities, wearing appropriate personal protective equipment, ensuring adequate ventilation, suitable environment for dispersing, and of course allowing gas detection using adapted monitors. Ensuring emergency procedures is also important in the workplace to allow reduce the risk. Now let's consider the mechanisms by which inhalation toxicant may produce their toxicity. We can classify agents in three categories. The irritant agents, they will be responsible for local toxicity, and their effects will mainly depend on their aqueous solubility. High soluble gases may affect the eyes and the upper airway, like chlorine, while low soluble gases will affect mostly deep pulmonary structures, since they may diffuse till alveoli, and this is the case of phosgene, for instance. Some of the cases, and we'll discuss it, hydrogen sulfide may have local and general toxicity. The second category is asphyxiant agents. They may just act by reducing the FeO2. This is the case, for instance, for alkanes like methanes and butane. And also in some cases they may reduce and alter oxygen transport and extraction by tissue like carbon monoxide or hydrogen cyanide. And finally, some agents may have systemic activity different from that of asphyxia, like arsen. Toxicity of these compounds is determined by the dose, their inherent chemical properties, their water solubilities, and their warming properties. One important rule when discussing gas toxicity is Haber's rule. And this is in relation to the relationship between the concentration of the poisonous gas and how long the gas must be breathed to produce its toxic effects. And you see that the relationship is a constant depending on the properties of the compound. And that means if you increase the concentration, then you need a shorter delay to obtain toxicity, while if you decrease the concentration, you will require prolonged delay to obtain the toxicity. And the relationship is always a constant, so that the relation between the concentration and the time is linear on a log-log scale, as shown with these two examples of chlorine toxicity in mice and rats. What are the principles of inhalation poisoning management? Of course, generally, there may be different and several persons intoxicated, and you have to make a triage, distinguishing between exposition and intoxication. You have, of course, rapidly to identify the life-threatening presentations, to determine and investigate the circumstances of exposure. Then you have to rely for diagnosis on the physical examination, the readily available biomarkers if possible, and immediately to indicate the therapeutic means, including supportive care, decontamination, elimination techniques, and antidotes if existing. You see, toxicological analysis will only come afterwards and only confirm your first hypothesis. So we'll take 3 examples and discuss management. 3 examples taken from different situations that may result in a consultant in the emergency department. First, smoke inhalation in the fire scene. Smoke inhalation may result from fire, and fire may expose to 3 dangers: thermal, traumatic, and chemical risks. About 80% of deaths at the fire scene are related to toxic smoke inhalation, and 80 of them will occur immediately, usually immediately on the scene, while 20% of them may occur lately in the hospital. Of course, smokes contain different compounds, thousands of compounds. Some are responsible for direct cellular anoxic toxicity, like carbon monoxide and hydrogen cyanide, and others are responsible for irritant toxicity, like soot. Of course, the relative production of carbon monoxide and cyanide depend on the environment. The presence of cyanide was suspected in the 70s when comparing the deaths resulting in fire victims at the upper side of the slide and CO poisoning. And you see here that in case of smoke inhalation victims, there is a risk of death, whatever the carboxyhemoglobin is, while in case of pure CO poisoning, only deaths are observed with elevated carboxyhemoglobin of more than 50%. Carbon monoxide, of course, will alter the capacity of hemoglobin to fix oxygen and result in a leftward shift into the oxyhemoglobin dissociation curve, while cyanide will attach directly to some ferric forms of vital enzymes like cytochrome oxidase in the mitochondria, resulting in anaerobic glycolysis. How to make the diagnosis immediately? There are 2 fundamental signs with elevated negative predictive values. First, the presence of soot in the airways, and second, the presence of neurological impairment. In the absence of both signs, there is no smoke inhalation toxicity. In pure carbon monoxide, you should know that vital signs, except Glasgow Coma Score, are generally strictly normal, including lactates, which are generally very mildly elevated. Whatever, as you see on this slide, the severity of carbon monoxide poisoning is, and whatever the neurological impairment is. However, in smoke inhalation, in the presence of cardiovascular impairment, abnormal respiratory pattern, or huge elevation of lactate concentration, you will suspect, with a relatively good predictive value, the presence of cyanide poisoning. You see here that lactate is a good biomarker for cyanide poisoning, and there is a relatively good relationship between the elevation in lactate concentration and the elevation of cyanide concentration, even though lactate is not so specific even in these circumstances. These slides show you some differences between cyanide and carbon monoxide poisoning related symptoms. And you see that headaches, dizziness, gastrointestinal symptoms, loss of consciousness are more related to carbon monoxide, while coma, dilated pupils, abnormal respiratory pattern, and hypotension are related to cyanide poisoning. The second kind of toxicants that will be inhaled are those who will result in irritations. They will irritate the eyes and the respiratory airways. In the eyes, you may have red eyes, burns of cornea, conjunctivitis, and those are predictive of associated respiratory injuries. Respiratory symptoms will vary according to the localization of the injury. You may have obstructive laryngitis, bronchospasm, and of course, chemical bronchopneumonia. The presence and the emergency department admission of dysphonia or rhonchi are associated with a longer hospital stay. The tracheal and the tracheobronchial injuries will involve complicated pathways. Chemicals will activate epithelial cells, chemokine release, alveolar macrophage, resulting in the production of superoxide species and increasing the exudative injury and the bronchoconstriction. On the scene, immediately, you will be able to determine the possibility of carbon monoxide exposition by using pulse carbon oxide oximetry or even atmospheric measurement. Pulse oximetry, the usual pulse oximetry, will fail in distinguishing between carboxyhemoglobin and oxyhemoglobin. You will also require to sample bloods for carbon monoxide measurement and further cyanide concentration determination, and of course, arterial blood gases. When admitted to the hospital, chest X-rays will be obtained. However, they are with low specificity and predictive values. Initially normal X-rays does not preclude further complications. In the ICU, microbiology of sputum may be interesting because, of course, bacterial aspiration is the first cause of complication. And bronchoscopy in burnt patient may have some predictive value. Rapidly, you have to decide the treatments. Of course, oxygen is immediate, and hyperbaric oxygen may be required in some cases, including consciousness loss, coma, neurological deficiency in children and pregnant women. Although you know that meta-analysis failed to demonstrate any benefit for hyperbaric oxygen to reverse and reduce neurological sequelae. In case of suspicion of cyanide, because this is based only on suspicion, you have to administer an antidote immediately at the scene or immediately after hospital admission. As you understood, neurological symptoms can be related to CO and CN, while the onset of any respiratory abnormality, any cardiovascular abnormality, a significant increase in lactate concentration are always related to cyanide. Thus, in these cases, you will suspect cyanide poisoning and administer an antidote. There are several possible antidotes. Sodium thiosulfate is probably the more natural one. It is efficient, safe, but with delayed activity, so not useful. Methemoglobin-forming agents are potent, but impairing oxygen delivery, so not useful. Cobalt EDTA is very potent, immediately active, effective also if lately administered, but it has numerous side effects, especially if administered in the patient who is not poisoned with cyanide. Thus, to my opinion, hydroxycobalamin remains the first-line antidote to administer. 50 gram will bind 1 gram of cyanide in stoichiometric relationship, and you can infuse 5 gram repeated till 10 in case of cardiac arrest with low expected side effects, except reddish discoloration of skin and urines. This is now thus the first-line antidote confirmed by USEM guidelines in 2012, and you see that administration is recommended in case of Glasgow Coma Score of less than 9, or in case of Glasgow Coma Score between 10 and 13 with an abnormal ABC. Rapidly, when admitted to the ICU, some non-specific but also some investigational treatments will be administered to the patient to reduce the injuries to the lungs. We'll use, of course, oxygen, humidified oxygen, protective mechanical ventilation, bronchodilatators, mucolytic expectorants. We will limit the fluid therapies to reduce the risk of pulmonary edema and rapidly give some antibiotics. Corticosteroids are not recommended, and several investigational drugs are currently used, including aerosolized heparin, Exoserv as surfactant inactivation, exogenous antiprotease, and of course, VV ECMO is probably one supportive important therapy today for these most severely intoxicated patients. You have also to consider the toxicity of additional compounds in the smoke, like volatile organic compounds. And you see at least 3 of them, benzene, nitromethane, and ethyl acetate, were remarkably found, detected in the blood of patients associated with high incidence and highly correlated with CO in these patients. All these injuries may result in complications, of course, immediate bacterial infections and hospital-acquired infections, but also late complications, including bronchiectasis, chronic bronchitis, and pulmonary fibrosis. Don't miss the risk of post-interval syndrome, which is a well-known cause of brain injury following carbon monoxide inhalation. The second situation we'll discuss rapidly is the workplace. Hydrogen sulfide is a circumstance of poisoning, may be responsible for poisoning at the workplace. It's a colorless explosive gas, usually characterized by rotten egg odor, although the sense of smell usually fatigues in seconds after exposure. It is naturally produced by putrefaction of different organic substances, and it is responsible for irritant and asphyxiant toxicity. And you see that symptoms will be in relation to knockdown effects, pulmonary, cardiovascular, neurological, and metabolic complications. More recently, in France, in the Caribbean islands, sargassum seaweed was responsible of mass poisoning with hydrogen sulfide, and you see even those seaweed were responsible for subchronic symptoms, including conjunctiva, upper airway irritation, memory loss, and modification of learning abilities. Management is mainly supportive, based on oxygen, irrigation of exposed skin and eyes, ventilatory support. Specific treatment is only discussed in case of persistent acidosis, coma, severe arrhythmias, with methemoglobin-inducing agents mainly. The third situation could be related to possible terrorist attack, with, of course, the risk of chemical warfare agents, and several episodes in the history illustrate this risk. Of course, probably one of the most scaring agents are organophosphorus compounds, and you know that they will act by inhibiting acetylcholinesterase, accumulating acetylcholine, and disturbing cholinergic functions, leading to bronchoconstriction, central respiratory arrest, paralysis, and inhalation. Clinical diagnosis is generally relatively easy, and to date, several readily available techniques could be used to allow immediate confirmation based on the measurement of cholinesterase activity in the plasma, or even the detection of the presence of organophosphorus compounds. Of course, you have to administer treatments, and one important issue is the administration of oxime, because as you know, the organophosphorus compound will immediately interact with acetylcholine esterase, and according to the organophosphorus compounds, leading to a covalent link with an aging enzyme, and thus a non-active oxime. Thus, the treatment relies on atropine administration to reverse muscarinic syndrome, benzodiazepines to prevent seizures, and of course, oximes that are required to reactivate the inhibited cholinesterase. And of course, as you see with the chemical warfare, probably prolonged oxime treatment is expected to be mandatory in the most patients. Of course, supportive care is also essential, with oxygen, mechanical ventilation, and self-protection of the caregivers to allow secondary contamination. So, in conclusion, gas and inhalation toxicants may be responsible for acute, life-threatening systemic and irritant respiratory toxicity. They are also sometimes responsible for chronic disease, resulting in respiratory and neurological disabilities. Smoke inhalation is probably one of the most important situations that an emergent physician could face. It's a polyintoxication. Cyanide plays an important role. While not uniformly present, it may often contribute to toxicity and lethality. Volatile organic compounds also should be considered, although to date their role is not really well known. Hydroxycobalamin is the first-line recommended antidote due to its safety and its efficiency in complement to oxygen and supportive care. And of course, many various gases and toxicants could be involved in inhalation toxicity, mainly at the workplace. Probably one important mechanism of action is just the reduction in FaO2 and management in these cases is mainly supportive. Thus, prevention and detection are mandatory. So before ending, if you're interested, and I'm sure about that, in toxicology, I would like to invite you to our PCCT Congress, the Congress of the European Association of Poison Centers and Clinical Toxicologists, that will be held soon in Naples, in Italy, during May. Thank you very much.
What do you think about contraindication of hyperbaric oxygenation treatment for carbon monoxide poisoning? Thank you.
The indications of
Yes.
hyperbaric oxygen, as in France at least, the number of centers able to provide hyperbaric oxygen is decreasing with time. Probably this is reflecting the fact that to date toxicologists do not believe anymore in the usefulness of this technique. I will not say that you don't have to do it. Probably send patients, those who are most intoxicated with neurological symptoms and probably loss of consciousness. The risk of post-interval complications is related to the importance of carbon monoxide. It is never observed with carbon monoxide of less than 20 to 25%. So at least the patients will present a loss of consciousness. But to date, we have to observe that there is no definitive evidence to support its usefulness to reduce the risk of neurological sequelae.
Thank you.
Thank you very much. More questions? Yes, please.
Thank you. Welcome again. I'm just wondering, in your practice, how often do you face with carbon monoxide inhalation?
In my practice, I'm an intensivist. I work in the intensive care unit. Unfortunately, our hospital has no possibility to deliver hyperbaric oxygen. So patients generally are not referred to our ICU. But this problem is now decreasing in France because of prevention. Although it remains relatively elevated, but it is decreasing. To my opinion, I would say in France there is about 5,000 poisoning per year in France.
Thank you.
Because now, for instance, the use of an alarm in private homes is mandatory for insurance purposes in all the homes in France.
Thank you very much. I guess we have more questions. No?
Thank you.
Thank you, Professor Margarben, for such comprehensive overview. And our next speaker is Professor Vimal Krishnan from India, who will talk to us about psychiatric consultation. When and for whom and for all whom?
Yeah. Hello. Thank you. Am I audible? Am I audible? In the back? Yeah. Thank you, sir, for the introduction. I'd like to thank the organizers. I'd like to thank EPAT, especially Professor Bausa, for having us here. The topic that has been allotted is psychiatric consultation for who, whom, and when. I think it's a very soft topic. When you look into the other topics that you've heard all through the day, we've had riboas and open thoracotomies in the ER and ARDS, and all those sexy topics have been taken on. So I guess what's left is the softness of certain topics which require a lot of decision-making from our side as acute care clinicians. Show of hands, how many emergency medicine clinicians here on the floor? Right. So the rest of you guys are critical care, is it? All right, we've got a mixed population here. I'm Dr. Vimal. I represent Emergency Medicine Association India, which is the largest association for Government of India approved emergency medicine specialists in our country. I come from a mission hospital. I work in a 2,000-bedded mission hospital in India. We cater to around 100,000 cases of 100,000 emergencies cases per year on an annual basis, an annual intake of 300 to around 500 cases per day. We do get quite a lot of infective cases in snake bites and inhalation injuries. CO, carbon monoxide poisoning is pretty common at our place, right? With regards to the topic, I'd say dissecting psychiatric consultations in the ER requires a lot of effort from the acute clinician side, because we tend to negate that they aren't a true emergency. You tend to feel that your emergency is run with trauma, with chest pain, with pediatric emergencies, with seizures, with pregnancy. You tend to overlook the fact that psychiatric patients need care too. Those patients who come to the ER, present to you in front of you, they need to be looked after in a different sense. But then we don't have that mindset, do we? We have a different mindset. Are we ready to tackle those in the ER? That's a big challenge. The question is this topic worth talking about? Is it a topic worth pondering on, psychiatric consultations in the ER? Is it hot topic? Is it hot property? I'd say yes. I'd say yes because literature supports it. If you look into literature, the waiting time of patients in the ER, it's 3.2 times that for the psychiatric patient. It's not because the psychiatric patient is denied care. It's because of a mindset for all the healthcare professionals working in the ER to claim that these guys will need care only later on. Let's look after all the other cases and then come back to them. So it's a mindset problem. What happens when a patient stays 3.2 times longer? The boarding time in the ER is protracted. And what happens when your time is protracted? When there's a lot of time in the ER, there's a lot of trouble in the ER. That's what I face. And that's what most of the senior clinicians over here would agree with. When the patient stays in the ER for a longer time, we've got bigger problems. US, this is what they say. They've got around 7 to 11 hours in the ER alone. And if you're transferring that patient to a different facility, he stays over for around 24 hours. Would you believe it? And if you look into numbers from India, it's very smaller with regards to the data which is mined out. But I'd say we'd be pretty better off. But I'd still say we'd have our priorities in the lower list for a psychiatric patient. Now, look into this. 90% of patients, physicians who were asked about what they do with psychiatric patients said this. We've got violent behavior from psychiatric patients. We've got issues with stress amongst the healthcare professionals who are looking after psychiatric patients. We've got the whole flow pattern in the ED disrupted because of psychiatric patients. So we're not very happy dealing with psychiatric patients. The decision making takes a toll on the healthcare professional. They're not happy taking decisions on the flow. Now they consume the scarce ED resources. Everybody here would agree with me that our resources are always scarce. With the emergency department, we want more every year. We get more patients every year. The need for the patients also increase on a yearly basis. We study new things. We get new tools. We try to implement newer tricks of the trade for the patient who's dying on us. But then we also tend to realize that time is the biggest commodity that we have. And we're losing out time when you're not looking after that patient. And if you look into the time frame that you spent with the patient, which is around 3.2 times delay, the patient stays for a longer time in the ER, and that ends up taking up a bigger chunk of time of your clinical work. What does it lead to? It leads to this. It leads to delayed attention to undifferentiated, chaotic patients who are waiting for you, who are really sick. Do you realize that there are patients who present to us as generalists in the emergency department? They're basically undifferentiated. They basically do come at 3 a.m. in the morning, very chaotic, in a chaotic environment. When the world is sleeping, we're working. It's tough taking decisions then. So patients with undifferentiated medical issues would be denied timely care because our focus is elsewhere. Our focus has been distorted due to the problems in the ER, the stress in the ER. Now I've established the fact that this is important. We need to take into consideration the patient in the ER. Now I'll start with a case scenario. Case scenario is pretty simple. The case scenario that would come to you any time of the day. An 80-year-old male who's a known schizophrenic, who comes to you with acutely altered sensorium. And the biggest problem that we face, vague historians. The patient doesn't give you a good history. The caregiver doesn't give you a good history. The only strong part is that he's hemodynamically stable. So you're comfortable. Oh, I'm comfortable. He's a hemodynamically stable patient, but he's schizophrenic. Now what happens next? You see the patient, and he looks like this. What next? So you'd say, let him wait there. I'll look after all the other cases, and I'll come back and take a look at him. But remember, any case that presents to the ER wouldn't be like this. Wouldn't be like the Mad Hatter from Alice in Wonderland. It's a very different game because patients don't present in black or white. Patients don't present with either being totally crazy or being completely actively good in the ER. They present in a chaotic sense. What do they present with? They present in the gray zone. They present as patients who are not either really good nor really bad. What do you deal with? You deal with triage in the ER. Is it a good tool? We've known earlier itself. In the hospital, there's no ideal tool. Professor Alvi has told about that yesterday too. It's not an ideal tool in the ER. What do you do next? You believe on your subjective feel. Okay, I don't feel that patient is good. Your head nurse comes and tells you, Doc, I don't feel that patient is good. You need to take a look at him again. That's when you realize that most of the patients who present to you aren't black or white. They're in shades of gray. And it is your job as the acute care clinician to figure it out where you are. Now, if you look into patients presenting to the ER with a psychiatric illness, they complicate things more because you've got 4 patients in the back of your head with trauma. You've got 1 coded patient going on. I've got 2 kids who are crying with trauma, needs suturing in the background. Oh, I've been called for an intubation in between. My resident calls me because he's got a crash in the ED ICU. In between, I've got a patient who's crazy. What do? I am more confused. My mind doesn't think alike. What do I look into? I look into the vortex of death. I talk about the vortex of death when you're dealing with specifically hard topics, like right ventricular failure in the ER. What do? You don't treat them like left ventricular failure. Right ventricular failure, if you treat them like left ventricular failure, they're going to end up with death. If you're going to intubate a guy with acute right ventricular failure in the ER, and you use your rapid sequence intubation sequence, that patient's going to die on you the moment you place a scope. That is what's going to happen. So what do you do next? You think of putting them in domains. You think of taking the whole psychiatry domain, breaking them into bits, and then specifically putting the patient there. I'll break them up very, very, very, very quickly. Thought disorders, people with schizophrenia. They've got thought problems, they're deluded. Most of the patients who come with acute delirium could have a medical issue. But remember, it might not always be a medical issue. Medical mimics do need to be cleared prior to tagging them that they've got a problem which is medical emergent or could be supracortical as a term, which is a very bad terminology. Mood disorders, people would come in with depression. It's on the rise. If you look into WHO, if you look into literature, you could read that the world is becoming more and more depressed, right? Or the other end of the spectrum, people could be bipolar and agitated. He'd come around shouting in the ER. He'd stress everybody in the ER. Right? Every healthcare professional in the ER would be stressed with him. A person would come down who is suicidal. Do you remember that any person who comes down with deliberate self-harm, he's taken something he's taken some poison, he's allegedly consumed something. You look at him with a different perspective. You look at him as a patient who's consumed a toxicological thing, and you look at the effect that the toxicological stuff has on him. But you take a step back and also remember that he's a human being who's been pushed to the limit to commit this. So there's a problem there. You need to call in their psychiatric consultants to help you out there. Anxiety disorder, with the world, with the brink of disasters and trauma on a big scale, post-traumatic stress disorders, post-disaster issues. We've had a tremendously great talk on disaster, a big session on disaster yesterday. Is it just physical? No. There are things which would hurt you mentally too. How do you do a triage for a person who's come down post-disaster, who's physically all right? You don't do the SALT or the STAR triage. What do? You do the PSY triage. You do the PSY STAR triage, PSY STAR triage. It's a tool that you use to figure out how good he is in his spectrum, how he's faring with regards to his acumen post the event. And I'd add these 2 domains too, somatoform disorders and malingering. It's a very thin red line between the 2. The somatoform guy doesn't know that he's got a problem, while the malingerer knows that I've got a problem, I've got a problem. I'm going to fool the whole scenario to gain out of it. The somatoform guy doesn't know that he himself is getting fooled, right? So if you could get them in either of these 7 domains, you're good to go forward. Now with this, I'd come to the heart of the story. It's always important to medically clear a patient who's come out with acute delusion or delirium, I'd say. But it's not easy. The psychiatrist, the psychiatric consultant at the other end would say, you just clear the patient medically and then admit under us. The internist or the general medicine guy would say, oh God, you need to get a clearance from the psychiatry side prior to you pushing the patient here. And then the neuro department would say, I think this guy needs to be evaluated medically first. Right? It's like the Thanos snap. We are supposed to clear out everything with limited information in limited periods of time. That is what they push us to do. What do? We deal with rules of thumb. I'll give you some rules of thumb. This is a general consensus. A patient who's really old, a patient who's got multiple comorbidities, and he's severely agitated with abnormal vital signs. Now these guys with acute comorbidities and co-ingestion of some toxic agents need to be evaluated medically prior to being pushed to the psychiatry section. Yes, we'd get a call from them later, but not now emergently. So anybody with abnormal vital signs, advancing age, severe agitation, on any acutely, if he's ingested anything acutely, he needs to be evaluated medically prior to being pushed to the psychiatry side. What about labs? How many of you guys use point-of-care stat lab in the ER? Point-of-care labs? Point-of-care labs? Yeah, you do your ABGs, you do your troponins, you do your biomarkers in the emergency department itself. We tend to do that. So there's an inclination for an acute care clinician to do a battery of tests for these guys. A battery of tests, right? A blanket of tests for any person who comes with altered sensorium. Oh, I got to do this. It shouldn't be that way. It shouldn't be that way because literature tells you that it's always better to be patient-specific and to have that intuitiveness on the clinician side to understand, okay, this patient doesn't need that blanket of tests. This patient needs these tests, but doesn't require that test, right? It requires your intuition, and it also requires patient specificity. Now, guidelines have come into this that routine labs are not warranted. It might lead to more confusion rather than more clarity. Now, psychiatry more than medical. You need to get them to the psychiatry more than medical when the patient's actively suicidal. You just can't keep them with you because you might end up on the wrong side of the boat. When the patient is actively suicidal, when the patient's dangerous to others, when the patient's got a psychotic event for the first time and you've cleared all the medical issues, or when the patient's so bad that he can't take care of himself, it precludes him for self-care. These are patients who need to be evaluated by the psychiatrist initially itself, not later on. You got to get him through the pathway, through the chain into the psychiatric pathway so that he'd get optimal care rather than just being pulled into the medical side. It's not working. Right. Now, if you just objectivity. We as acute care clinicians, we tend to be more objective. I've got pain in the ankle. I'll do the Ottawa angle rule and then think whether I need to do an X-ray, right? We got a patient post-trauma with altered sensory, we try to do a GCS. We got a small child with head injury, we try to do a Pecan rule to make sure whether you need to do a CT in this child or not, right? We tend to risk stratify them, we tend to objectify them. Now, DSM-5 criteria, it gives that objectivity that you need when you're looking after patients who are coming from the psychiatry realm, who've got acutely delirious, who've got a history of psychiatric issues. You need to do the DSM-5 criteria. For suicidal ideation, for patients with suicidal ideation, you think of using scoring systems. Again, there are different universities with different scoring systems. Columbia is one of the scoring systems that you can use. The safety triage system, which is suicide assessment and 5-step evaluation method. It's an excellent tool which universities do use to risk stratify guys with suicidal tendencies. So they do end up with the psychiatry department only after these tools are used, and they're stratified that these guys need to go into the pathway with psychiatry friends rather than with the internist in the department. To summarize, when and whom would you call for a psychiatric consultation? I'd say a person with substance abuse definitely needs to be evaluated by the psychiatrist, a combative patient after he's medically stable, a patient with deliberate self-harm who's got suicidal ideation, a person post-disaster who's traumatized post a disaster or traumatized post a traumatic incident needs to be evaluated by the psychiatrist. But I'd say it's not just them. What about us? We're always talking about the patient. I think there's a lot of focus on wellness today. There's a lot of focus on the clinician who's taking care of them. We've seen yesterday fantastic lectures from Dr. Alvi, Dr. Casio. We've got stalwarts in the field of disaster medicine coming and telling us that we've been there all around the globe helping people, in disasters. But when we come back, a part of us stays there. We come back as a different person. So, like he reiterated in his lecture, we need to talk to the right person, to make us feel whole again. Healthcare professionals, nurses, doctors, paramedics, technicians, people who are there in the forefront at war zones, they need to have that sort of connection with the psychologist to just extract what's burning them from inside. Let's not push healthcare professionals to burnout. So stress and the impaired healthcare professional needs to have an evaluation from the psychology side, which again comes under the bigger umbrella of a psychiatry department. Beyond the medical issue, or summarizing why we need consultation, why do we need it? My first 2 slides focused on the literature review on why we need decision-making in the ER for psychiatric patients. System problems, EM systems, overholding the emergency department, staying too much in the department, leading to more of morbidity, mortality in the department, too much stress for the healthcare professional in the department. It all adds up. You need an optimal disposition plan for a patient with psychiatric ailment. And beyond the realm of medicine, you're going into the realm of psychiatry. So it's always optimal for that patient to walk into your clinic or your ER, find out whether he's got a medically relevant problem which has pushed him to this, and then get a clearance from your side and move towards the realm of psychiatry. The future, I don't know, I don't think so that anybody can predict the future. There aren't any Nostradamuses around. It's very difficult to predict the future. But what we'd say is we'd extrapolate the little information that we have today to draw lines on what could happen in the future. So if you ask me, there is no pill that can be given that can tell you that you could take this pathway and that's going to happen in the future, or that pathway and that could happen in the future. It is never going to happen that way. It's more complex than that, and science is evolving at a different pace. What I can tell you is we have telemedicine. We had a fantastic take on digitalization in the emergency room by Dr. Barbara Hogan, and she spoke on how telemedicine could help us. Telepsychiatry, there are umpteen articles which are coming up on telepsychiatry, how that could help, overcome the problems of psychiatric patients holding in the emergency room, how overcome the problems of not having psychiatry support in my institute if there isn't any. So you could have that. Observation units are taking the world by storm. There's a lot of controversy to observation medicine. There are people who claim that, insurance guys do save a lot of money, but then it's not that good for the patient. It adds a whole lot of load for the emergency department, about the staffing in the emergency department. So OUs, psychiatric OUs, it's been studied now that POUs, or psychiatric observation units, do help decompress the pressure which is there in the emergency room. Push the back pressure for not admitting these patients and those patients holding up in the ER could be relieved by having psychiatric observation units. And I'd say the most important part would be risk stratification tools and algorithms. We're not coming together and developing consensus guidelines on risk stratification tools for the psychiatric patient, because that is not hot property. You talk about chest pain, we've got consensus statements. You talk about traumatic brain injury, we've got consensus statements. You've got pediatric seizures, consensus statement. Pulmonary embolism in pregnancy, consensus statement. What about psychiatric patients? What about disposition plans for psychiatric patients? So we need to have different associations coming together and forming psychiatric patient, forming a guideline for the psychiatric patient. The case scenario, the 80-year-old male, schizophrenic, altered sensorium, vague historian, hemodynamically stable. I still know that it's not easy. I still know that that patient would look like this wolf hiding behind the herd of cattle. It still isn't easy. But then it is your intuition as a clinician. It is your duty as a person who could integrate multi-department and could facilitate dialogue to form a protocol which could help you to take a better decision in your institute. You could be the end of the puzzle. You could be that piece which could help fit in a complete plaque for the betterment of patient care. And I'd say our role is to integrate between different specialties. We are interfacing with the public, we are interfacing with a psychiatrist, we are interfacing with the intensivist, with a surgeon, with the hospital administrator, with the police force. We are interfacing with almost everyone. So I guess we have a role like this, the guy in the center. And I'd end my talk with this quote by Napoleon. Because Napoleon once said, the world is suffering a lot, and it is not due to the violence of bad people. It's due to the fact that we are more silent, the silence of good people. Let's keep on talking, let's initiate dialogue, let's get more people in the room and form consensus statement for the betterment of patient care. Thank you, ladies and gentlemen. These are my references. I'd like to invite you to the national conference which is happening in India. It is happening at the end of July, beginning of August. We're having it in the beautiful capital, New Delhi. So you could fly down during this time. We'd be happy to host you guys for our national conference. I'd also invite you, because I'm the board member for the World Academic Congress in Dubai. I'm part of the board for the World Academic Council. We've got multiple leaders here from the World Academic Council. So the World Academic Congress for Emergency Medicine specifically focuses on a TED Talk format pattern with speakers from all around the globe in Dubai this year. So do come for that. That's coming up in October, and it's going to be a fantastic time. We're going to have a fantastic time there. Thank you for your patient listening.
Thank you very much, Professor Vinam. So please, your questions. If I may, I have a question. So in ideal situation, in the end of the day, for your opinion, what should be first, the primary psychiatrist background for this kind of patient, or primarily ER background?
The ER. What we've done is we've had written statements in collaboration with the psychiatry department and the internal medicine department. The internist in the hospital, the psychiatrist, and the emergency medicine guys, they sit down, they troubleshoot, brainstorm, and form a guideline on what we should do with a patient who's got a mood disorder, what we should do with a patient who's got a thought disorder, what we should do with a somatoform disorder. So we get a guideline which is down, and then we stick to that. We revise that guideline every time with a morbidity audit that we have in the emergency room. So I think the way forward would be integrating those basic sciences together, and to regularly do audits so that you could correct and evolve at a better pace.
Thank you.
Thank you.
Thank you very much.
Thanks.
And dear participants, our final presenter for this session is Professor Polat Durukan from Kayseri, Turkey, which will highlight us the topics which patients should be in ICU.
Dear
Professor Durukan.
Yeah. Dear moderators and audiences, I think this will be the last talk in this session. And I will talk about which patients should be in intensive care units. We all know that we have very limited and expensive resources for the intensive care units. The cost of critical care in the United States was estimated to range between 121 to 263 billion in 2008. Crowded intensive care units, delayed admissions of critical ER patients, care delays, and other delivery inefficiencies are also problematic issues. These concerns forced the medical community to act smarter and evidence-based on this matter. Thus, in 1999, the Society of Critical Care Medicine published guidelines for the intensive care unit admissions, discharge, and triage. Given the fact that medical expenses are not getting smaller and emergency rooms are still and intensive care units are not getting emptier, the topic is still a current challenge for both intensive and emergency caregivers. It's also a big problem, I mean the number of ICU beds in Turkey. So which patients should be admitted to emergency ICUs is a very important question. It's reasonable to develop policies to meet specific population needs, such as trauma, burns, neurological pathologies, sepsis, and take into consideration the institutional limitations, such as ICU size and therapeutic capabilities or number of medical staff. To optimize resource use while improving outcomes, hospitals should give ICU admissions on the basis of a combination of various parameters. These parameters are specific patient needs that can be addressed only in ICU environments such as life-supportive therapies, available clinical expertise, prioritization according to patient's condition, diagnosis, bed availability, objective parameters at the time of referral, and potential for the patient to benefit from interventions. Prognosis is also important. We can discuss three models for guiding admissions of the patients to ICUs. These are prioritization model, diagnosis model, and objective parameters model. Deciding priority is very important. Patients are categorized in the prioritization model. Patients are categorized by 4 priority levels based on how likely they are to benefit from admission to ICU. In the priority 1 level, critically ill patients who require life support for organ failure, intensive monitoring, and therapies only provided in ICU environment. In the priority level 2, we have patients, as described above, with significantly lower probability of recovery and who would like to receive intensive care therapies, but not cardiopulmonary resuscitation in case of cardiac arrest. In level 3, patients with organ dysfunction who require intensive monitoring and or therapies. And at the level 4, patients as described above with lower probability of recovery. These patients, for example, with underlying metastatic diseases. And for palliative care, at the level of priority 5, terminal or moribund patients with no possibility of recovery, such patients are in general not appropriate for ICU admissions. In the diagnosis model, a list of specific conditions and diseases is offered for deciding which patients should be admitted to ICU. For example, some cardiac system abnormalities like acute myocardial infarction with complications, cardiogenic shock, some pulmonary system diseases, acute respiratory failure requiring ventilatory support, pulmonary embolia with hemodynamic instability, some endocrine disorders, some neurological disorders, acute stroke with altered mental status or coma, maybe examples. Some endocrine disorders, for example, diabetic ketoacidosis. Some life-threatening gastrointestinal bleedings may cause ICU admission, or drug ingestion or drug overdose may cause ICU admission. Some postoperative patients requiring hemodynamic monitoring or ventilator support, they also may need ICU. And we have some miscellaneous causes, for example, septic shock with hemodynamic instability, clinical conditions requiring ICU level nursing care. They may also need ICU admission. In the objective parameters model, the last model, the specific vital signs, laboratory values, imaging or electrocardiogram findings, and physical findings are offered for deciding which patients should be admitted. But unfortunately, all these models have limitations and none have been properly validated. If we look at the literature about the admissions, in a study, they suggest that admissions to the ICU should be based on functional impairment rather than just severity of illness. They showed that functional impairment at the time of intensivist evaluation was the determining factor influencing ICU acceptance. Patients were less likely to be admitted if their functional status was poor or they had a do not resuscitate order. In another study, their data, after studying a program in which abnormal vital signs were used as criteria to trigger patients to be admitted to ICU until their conditions improved or stabilized. Another study here, you see, they suggest that respiratory rate alone should be a major determinant for ICU admissions, but there is not a reliable list of objective indicators or their respective specific thresholds for identifying candidates for ICU admissions. On the other hand, in another study, we see that they showed that the sensitivity and specificity of abnormal vital signs to predict death or ICU admission at triage were only 73% and 50% respectively. In another study, we see that they investigated the feasibility of using a triage score to assist in deciding about ICU admissions. The score is incorporated with age, diagnosis, vital signs of the patients, was a procedure used, or operative status, chronic disorders. These are all related issues. What about QSOFA? In 2016, a task force have described an assessment score for patients outside the intensive care unit as a way to facilitate the identifications of patients potentially at risk of dying from sepsis. This score is a modified version of sequential organ failure assessment score called QSOFA or QSOFA. A score 2 or more than 2 is associated with poor outcome due to sepsis. QSOFA score is easy to calculate since it only has 3 components. You see, we have respiratory rate, altered mental status, and systolic blood pressure. In 1999, a group of experts appointed by the Department of Health in the UK suggested that patients in hospital should be assigned a level of care based on an assessment of their clinical needs, regardless of their care locations. In their review of critical care services published in 2000, they described these levels as level 0, regular hospitalized patients with no intensive monitoring or care requirements. Level 1, patients requiring additional monitoring such as continuous electrocardiographic monitoring. At level 2, patients requiring more frequent monitoring and interventions such as those with single organ dysfunction which cannot be provided in previous level. Level 3 patients, these are requiring life supportive therapies such as those with single or multi-organ failure which can only be provided in the ICU. In Turkey, we also use this leveling process. It is used by Ministry of Health for the assessment of intensive care units in Turkey. So we need some guidelines. Recently, Society of Critical Care Medicine published guidelines which also questioned ICU admission criteria. These guidelines are, for example, avoiding admitting patients to a specialized ICU dose primary diagnosis is not associated with that specialty. We should admit neurocritically ill patients to neuro-ICU, especially those with a diagnosis of intracerebral hemorrhage or head trauma. Each institute should develop individual methods for prioritizing and triaging patients. Triage decisions should be made explicitly and without bias. Ethnic origin, race, sex, social status, sexual preference, or financial status should never be considered in triage decisions. Under ideal conditions, Patients should be admitted or discharged strictly on their potential to benefit from ICU care. So these patients, in general, patients admitted to the ICU should meet one or more of the following criteria. For example, patients requiring care involving specialized competence of ICU staff that is not widely available elsewhere in the hospital, and patients having clinical instability, and patients being at high risk of imminent decline, they should be admitted to ICUs. Who should make the decision? It is reasonable to have a designated person or service with control over resources and active involvement to be responsible for making ICU triage decisions during normal or emergency conditions. What about terminal cancer patients? In particular, cancer patients with advanced disease, it is reasonable to discuss care options with the patient next of kin, legal representative, or power of attorney. Oncologist or hematologist opinion regarding life expectancy and palliative solutions should be taken into consideration. ICE triage in epidemics, it's an important issue. Non-traditional settings should be considered and utilized for the care of critically ill patients. Using routine laboratory studies or scoring systems alone in determining the nature of illness during an epidemic might be misguiding. All hospitals and regional areas should develop a coordinated triage plan for the epidemics. And in mass casualty events, the disaster response team should identify all patients in need of intensive care unit care and those already hospitalized who could be discharged. Then triage and transfer incoming patients to the most appropriate settings as soon as possible. Thank you for your attention.
Thank you very much, Professor Polat. So we still have time for questions. Please. So no questions. Nevertheless, thank you very much again for a fantastic presentation. Thank you. So dear ladies and gentlemen, the agenda is over for this session. We have been delighted to hear so during this session, the highlights of the management of inhalation intoxications, the tricks in psychiatric consultations, and very comprehensive overview about the patients who should be in the ICU. So thank you very much and enjoy your evening.
So clear to me, it's where I need to be.
Değerli arkadaşlar, bu 4 günlük 9 salonda olan, gece 9'a 10'a kadar süren, her anını değerlendirmeye çalıştığımız kongreyi hep birlikte başardık. Son ana kadar yanımızda kaldığınız için, son ana kadar bizimle birlikte olduğunuz için çok teşekkür ediyorum. Biz büyük bir enerjiyle bunu yapıyoruz. Bakın dün gece Zeynep Hanım'la gece 1'e doğru kongrenin çalışmalarını planlamaya başladık. Çünkü yönetim kurulu toplantımız 12.30'da bitti gece. Sadece yönetim kurulu değil, dergi toplanıyor bir tarafa, yeterlilik kurulu bir tarafta toplanıyor. Dolayısıyla bu kadar yoğun bir tempoda geçirdik kongreyi ve biz hedeflerimize ulaştık. Yapmak istediğimiz şeyleri gerçekleştirdik. Ama biz hep daha yukarıya gitmeye çalışıyoruz. Bir sonraki kongrede bu yüksek atlama. Hep çıtayı daha yükseğe, rekoru daha yukarıya taşımaya çalışıyoruz. Bir aile gibi olduk. Özellikle International aile. Roger Dickerson sürekli yanımızda. Eric Revel sürekli yanımızda. Adam Carlos eklendi. Kanada'dan Jim McEwen hep yanımızda. Biz büyük bir global aile haline gelmeye devam ediyoruz. Burada yaptığımız her işlem uluslararası arenada ses getiriyor. Biz sadece lokal bir organizasyon yapmıyoruz. Kıtalar arası bir yapıya bürünmüş durumdayız. Yıl boyunca 300'ü aşkın aktivasyonumuz var. Gerçekten bunu birçok kişi duyduğunda bunun ne kadar yani inanılamayacak bir şey olduğunu söylüyor. Şimdi sizden beklentimiz şu, lütfen bu dev yapının altına girerek siz de omuzlarınıza alın. Herkes o bir şey alıyor, daha fazla girin. Biz de yükün altına ne kadar çok girerse o kadar çok değerlisin. Ve bu çalışmalarımızın karşılığını hayatınıza mutlaka bir şekilde alacaksınız. Bu kadar büyük çalışmaları daha büyük ekiplerle yapmak gerekiyor. Dolayısıyla bu kongrede biz buna çok dikkat ediyoruz. Ve geleceğe taşımak istediğimiz veya geleceğe beraber yürüyeceğimiz kişileri bu kongrede belirliyoruz. Keşfetmeye çalışıyoruz. Biz bu kongrenin başlangıcında başlığı ne atmıştık? Bir hatırla. Afşin sen önündesin değil mi? Başlığı hatırlıyor musun? Ön sözün başlığı. Dikkat ölçüyoruz. Geleceğe yürüyüş. Geleceğe yürüyüş. Biz hep birlikte acil tıbbın geleceğine birlikte yürüyeceğiz. İnşallah. Onun için de hepinizden alacağımız güce, enerjiye ihtiyacımız var. Ya beni hoca aramıyor, ya ben burada etkili değilim, ya ben burada yok. Böyle bir şey yok. İkincisi biz sağ bek istemiyoruz arkadaşlar. Sağ bek istemiyoruz. Biz orta saha oyuncusu istiyoruz. Ya da forvet istiyoruz. Sağ bek nedir? Ya bunu yakala, görevini yap. Ya görev değil ya, tamam ben sana söyleyeceğim o görevi yap. Bu adamı oradan geçirme, onu istemiyoruz. Sen oyun kur, oyun. Bana oyun kuracak eleman lazım. Ben sağ beki ne yapayım? Sağ bek dünyada bir sürü var. Ama oyun kurucu bulamıyoruz. Alex gitti sonra ne oldu Fener'in hali görüyorsunuz yani. Oyun kurucu yok yani. Oyun kuruculara ihtiyacımız var. Sağ beklerimizi her yerlerde bulabiliriz. Onun için sizden ricam oyun kurun, oyun kuracak, tabii bunu yanlış manada anlamayın yani, oyun kuracak elemanlara ihtiyacımız var. Dergilerimiz, televizyonumuz, gazetemiz hepsi sizi bekliyor. Lütfen sadece basit bir dernek mentalitesiyle bu işi düşünmeyin. Dev, vizyonu büyük, örnek, lider bir kuruluş olarak düşünün bizim yapımızı. Ve bu bir lider yapıda ne kadar çok görev almak isterseniz o kadar çok önünüzü açacağımızı bilin. Son ana kadar bizimle berabersiniz, yola gideceksiniz. Yola gitmeden önce adet üzere baskın seçim yapıyoruz. Espri yapıyoruz. Ya soruyorlar seçim var mı ya? Seçim yok, seçimin bir zamanı var. Zamanı gelince size açıklayacağız. Dolayısıyla sormayın. Genel toplantımızda korkmayın. Ama ibra istiyoruz. Bizi ibra ediyor musunuz? Yani ibra, yani güven oyu veriyor musunuz? Bak güzel yaptınız bu kongreyi diyor musunuz? Biz hep birlikte bu kongreyi çok güzel yaptık. Hepinize çok teşekkür ediyorum ama şunu istiyorum. Lütfen şöyle bak biz burada diyorum ya gece başladı. Ben şimdi eve gideceğim belki yarın, bilmiyorum. Dönüş uçağımı daha onu bile ayarlayamadım ama şey var. Cuma günü yoğun bakım kursumuz var Ankara Şehir Hastanesi'nde. Oraya gideceğiz. Cuma, cumartesi. Yani bizim 3 gün dinlenme, 4 gün boş kalma gibi bir şeyimiz yok. Şansımız yok. Burada şunu da söylemek istiyorum. Özellikle yabancı dinleyici arkadaşlarımız zaman biz uluslararası üye de kabul ediyoruz. Erik'in son dersini kaçırmayacaktınız. Atüder'e yaptığı çok güzel bir jest vardı değil mi? Atüder görenler oldu. Sosyal medyada göreceksiniz. Yani bu kadar bizim içimizden biri olmuş artık konuşmacılarımız. Erik'e de bu yüzden özellikle bir alkış rica ediyorum. Erik. Gelecek günün sekreteri. Please for Erik. And Roger Dickerson. Biliyorsunuz en renkli sunum herhalde Roger Dickerson'ı da bu yüzden alkışlayalım. Arkadaşlar, hepinize başarılı, güzel bir gelecek, uzun, başarılı, sağlıklı bir ömür dilerim. Yolunuz açık olsun. Dışarıdan geçerken kitap alabilirsiniz. Kitap almayanlar kitap alsınlar. Bu büyük ailenin fertleri olarak hepimiz daha ileriye birlikte yürümeye devam edeceğiz. Saati şimdi mi vermiştik? Niye geliyor? Yok devam edin. Arkadaşlar buyurun, hepiniz gelenler oldu da onun için söylüyorum, ben bitirmek üzereyim. Hepinize iyi yolculuklar diliyorum. Bana her zaman ulaşabilirsiniz. Yönetim kurulumuza her zaman ulaşabilirsiniz. Büyük bir ailenin ferdi olmaktan, sizinle birlikte çalışmaktan, sizinle aldığımız bu enerjiyi büyük bir hizmete dönüştürmekten çok mutluyuz. Hepinize iyi günler, ve emanet olun.
Topic to talk about. It's not how good is an MRI, as important as how feasible is to have an MRI, and how effective and how practical is to have an MRI in the emergency department. I don't think anyone would doubt that MRI is a great wave image. So what I'm going to talk about, first I have nothing to disclose, so I'm just going to take it off the list. So I'm going to talk about one slide of physics so I don't bore you guys, and some justifications for MRI, as well as definition and types of MRI, utility in the ED, and some brief quick take-home messages to take from my talk. So physics, what you need to know about MRI, just like you need to have three elements for an MRI machine. You need a strong magnetic field, you need a radio waves, and you need a good computer system to be able to generate the images. Don't worry about what I'm having here, just look at the picture. So if you look at the picture, really it all targets the hydrogen proton that you have, it's a single proton, and you activate the magnetic field, then you kind of give an impulse of radio wave, then you stop those radio waves, then the organization of the proton pumps happens again, then the computer will be able to generate the image. This is what you need to know about the MRI machine, really nothing more than that. So, justification, as I mentioned in the beginning, choosing the right modality imaging in the ED is very challenging, and we always fight with our colleagues in the radiology department. When we order a CT, they give us a hard time sometimes. Why are you ordering the CT? Why are you ordering CT with angio? Imagine we're going to tell them, okay, now we want to order MRI directly from the ED. So we really have to have a good justification why we're ordering the MRI. So that's on the shoulder and burden on ER physicians. We should understand why we're ordering MRI, when to order MRI, and the utility of MRI. And we should ask ourselves,
is the MRI going to change my management in the acute setting in the emergency department, or it can be postponed and be done later on the admission phase or on the second day? So do we have to bring the technician from home, open the MRI, or no? Also, when we think of MRI, we should think of the cost. Many think MRI at least costs us twice as CAT scan plus an extra $100. It depends on the place. However, sometimes it is the most appropriate test. Then it's okay, it's fine, it's justifiable to do this. Availability of MRI, most places don't have it. Most places, I would say, in the US don't have MRI 24/7 with technician. I think the shortage of technician is an issue. Also, availability of radiologists who can read the MRI in 24/7 basis is challenging. So before asking yourself the question, should I start MRI in the emergency department? Do you have enough manpower to read those images? You don't want to do an MRI and wait 7-8 hours for the radiologist to read it. So this kind of contradict the whole idea. You need an MRI to make a fast, quick decision. If you're going to read it the next day, then why bother even with getting an MRI in the ED? Caution and contraindications, we're going to speak about them of MRI, also impact your flow and your operational value of getting an MRI. So, funny enough, my colleague, he's a radiologist, he's the head of the department. He sent me an image on WhatsApp yesterday. So I thought it was hilarious. He didn't know what I'm talking about. So you should start with seeing the patient, then obtain some history, then get some physical examination, then order a CAT scan. But like, they make fun of us and emergency doctors, just go ahead and get the CAT scan. And I think one of our colleagues today is going to speak about history and physical examination. Should we quit doing history and physical examination? So imagine if I showed this and send it back to my friend, adding, okay, don't even bother with CAT scan. We're just going to start with our eye and our patients. So that was going to be kind of, this is going to give them stroke if we do it. So, common ER MRI indications. So I was asked to speak about brain MRI only, but common, like usually most of the time it's used in the neuroimaging. You can scan the brain, the spinal cord, arterial dissection for infectious processes, also for pregnant patients, basically for the abdomen, also children, and MSK, especially orthopedic sports related injury, all the athletic know that that's the best way of modalities. Whenever ordering an MRI, even if you think it's practical and useful, you should take into account and consider what are the precautions, what are the contraindication of getting an MRI. As I mentioned, cost, claustrophobia, inability to patient stay still, and any devices or metals implanted on these patients. And let's be practical. If you ask the patient through the screening list, do you have any metals? They can say yes, but do you know if this metal is compatible with the MRI machine or not? You will take a couple of minutes, sometimes it will take 30 minutes or an hour to identify if this metal or object is compatible with an MRI machine. This will add to the operational problem you have to start with. It will delay getting the MRI and will delay the whole benefit of the whole thing. You need a quick decision to make. So this just kind of point out for you the different types of MRI and what are you looking for. So in the first, I don't think this is working. So the first part is like looking at the parenchyma. So the MRI you want to get a diffusion weight MRI. Its benefits, it's very sensitive to early ischemic changes. It starts in minutes and can get it out. Challenges, as I mentioned before, usually availability. If you want to assess the vasculature, always think of MRA, magnetic resonance angiography. It gives you full details and it does not require any contrast to do an MRA. Tissue perfusion, CT perfusion or MR perfusion, and it gives you wonderful resolution. Again, all of them, the challenges would be availability and time value. And this just give you the differences between the diffusion and the non-diffusion CT, and you can see the different clearance of the image. And when we talk about diffusion, perfusion, and the mismatch to identify the penumbra, and this is what you get, and this is how neurologists assess the need for mechanical intervention or any thrombolytics. So, a couple of important points about brain MRI. There is no standard imaging protocol for any acute stroke or TIA, except everyone agrees you have to start with a non-cone CT. After that, it's completely institutional dependent. It depends on your institution, it depends on your infrastructure, and what materials you can bring to it. What is the goal of neuroimaging? You want to provide rapid information to the physician. You want to increase the provider decision making with regards to reperfusion therapy without causing harm from delay. So again, if the MRI is going to delay your decision making, there is no point of doing the MRI in the ED, then it's not the best test for you. We all agree, and evidence agree, MRI has significantly greater detection rate for acute ischemic infarction. CT scan have 73 to 88% in the first 12 hours. MRI sensitivity is 93 to 100% in the first few minutes. So you can't really compare them. Not all acute stroke requires intervention, so MRI might not be indicated emergently if you think your patient would not benefit from an intervention. So there is no point of getting the MRI for this patient. Just to show you some recommendation on what people are recommending, the American College of Neuroradiology and the American College of Radiology and the Society of Neurointerventional Surgery have made a joint statement regarding DIA and stroke. They say non-contrast CT with digital angiography or non-con with CTA, MRI with MRA, or equivalent options for clinician. So which one you should use? They said we recommend to use the CT-CTA since it's available for everyone, easily obtainable, and the turnaround time is very fast. If you're able to make your MRI and MRA as good as CT and CTA in terms of the turnaround time, so you do it, you're able to read it, you're able to make a decision, then yes, go for MRI. It's much better choice. I like, there is no much evidence to say emergency department MRI. I only found like 1 or 2 papers, and this one is really kind of nice paper, but it doesn't talk about acute emergency department. They wanted to assess the MRI utilization and ED observation unit. So those patients came to the emergency department, they made a decision to admit them, but they don't want to admit them to the medicine floor, just to the ED observation unit. So this was a single trial, retrospective, 2013 to 15. They had around 25 or 24,000 patients. 19% had at least one MR, 62% of these MRs were brain MRI, 31 were spine. So as you can see, the neuroimaging agrees with what we mentioned before. It was like around 93% of the MRI is used for neuroimaging. So they did not find any significant difference between the median length of stay for patients who had an MR or patients who didn't have an MR. This again goes with the point I mentioned in the beginning. It is more of an operational question than a clinical question, the utility of the MRI in the emergency department. The limitation of this study was a retrospective single. They did not assess for the chief complaint, nor the reason for order, nor for the outcome of the patients. So I love the studies or the papers when they have, the capsule for the readers, and they ask you 4 questions, what you're adding and how you're going to change the practice. So this is what they say, well, how does this improve the population health? MRI are regularly performed in observation unit, and we should focus on determining which MRI are appropriate and which can be done as an outpatient test, and also consider the cost. This is a wonderful paper. You can take a picture of it, you can read it. It talks about all the MRI modalities in the emergency departments, the pros and cons for every single modality. I'm just going to mention a little bit about what they mentioned about the MRI of the brain. So the 2018 guidelines for an early management of patient with acute ischemic stroke, CT or diffusion-weighted MRI with perfusion, both recommended and considered equal in patients with selected for mechanical intervention. This guideline was also promoted by the American Heart Association, American Stroke Association, and endorsed by the Society of Academic of Emergency Medicine and many other societies as well. So I like this paper. It was done in Nevada and Phoenix in the United States. Introduction of dedicated emergency department MR machine to see if it's going to facilitate their work. They have a full neuro centers. So they looked at how it's going to reduce the number of CTs. So their conclusion were, can I significantly reduce the number of CTs in the ED by providing what? Diagnostically superior and safer imaging alternative to the CAT scan. This was achieved by a couple of points they had to do to reach this result. They alternate their MRI imaging workflow. They alternate the existing protocol of the scans. Both emphasize the efficiency and the patient throughput. Again, this tells you it's an operational question. increased confidence in clinical decision-making for the ED physicians, and MR imaging, technologists and neurosurgery residents were the only people in the study kind of didn't like, when they did a survey, they didn't like the option of having an MRI. Basically, neurosurgery resident, because MRI is very sensitive, so they were called more frequently to assist patient, even though it was like non-significant finding, and the technologists, they had to stay and work more hours to be able to do the new protocols. Then they really did not address, or they didn't have enough evidence to address any improvement in the patient outcomes. This just tells you the protocols that they created. The whole idea, have a protocol so you make it easier for the emergency physician when he wants to do a specific study. He doesn't have to think or order, then reorder, then call the radiologist or the neurologist to pick the right protocol for the specific problem. And this is how they changed the flow. It's wonderful. See the time that was taking to send the patient from the emergency department to the 4th floor to do the MRI. And then when they reinstitute the whole process and had the MRI in the last lower picture inside the emergency department, they were able to save a significant amount of time in getting the MRI. This another protocol I found promoted by many institutions. Just have protocol for your physicians. Brain MRI, reason for the exam, what is the best modality of MRI? We assume that emergency physicians do know all the MRI modalities for the specific pathology. That's not true. That's not true. We should make it easier for you to order which kind of MRI with gadolinium or without contrast for which pathology, based on a protocol agreed upon by neurologist, neurosurgeon, and emergency department, and radiologist at the same time. So, as promised, I'm not going to take more than 15 minutes. My big home message, it is an operational question more than a clinical question. And the use of MRI by emergency physicians has been increasing. We can't stop that or deny it. It's critically important for emergency physician to understand the basic of the imaging modality, indication for MRI, limitation and obstacles for MRI, and know your cautions and contraindications before you obtain an MRI. All these may increase the time, turnaround time for your MRI. Well, with that, I conclude my talk and will be happy to receive any questions. Thank you very much.
Thank you very much for this excellent talk, Dr. Canlı. Is there any question or any collaboration? Please.
Thank you for a good presentation. Sir, do you have any idea more than 2 Tesla MRI effect of body, long-term effect on body?
So that's a wonderful question. I put slide in the beginning. There is no evidence that says it causes harm so far. Even they did it in a pregnant lady. They had 2 big, large group, I don't recall the number, around 2,000. They couldn't find any long-term effect. However, the problem is usually with the contrast, the gadolinium. So the gadolinium does cause some nephrotoxicity, but now they're using different modality of the contrast that really doesn't cause much harm. So that is that evidence proven problem with the MR. But the MRI per se by itself, even for pediatrics or for pregnancy, there is no any evidence until now that I'm aware of that says. If you have any ideas, I'll be more than happy to hear from you.
Thank you.
Thank you, Dr. Canlı, please.
Hello everyone, now I'm using a different hat and becoming a moderator. So it's my pleasure to introduce the next speaker, Dr. and Professor Kumar. He's a consultant and head of Department of Emergency Medicine, Deputy Head of Clinical Operations, Dr. Mehta's Multi-Specialty Hospital, and he's a National Joint Secretary of the Society of Emergency Medicine in India. He's course director of multiple programs. He's a member of the Royal College of Emergency Medicine and Masters in Emergency Medicine. So please welcome him to the board. He will be talking about double-edged knife contrast medium in the emergency department. Thank you, Doctor.
Thank you very much, dear chairpersons, and it's my pleasure to be here. This is my 6th visit to Turkey, and it's always wonderful to come and meet all great friends here. And my talk for today is going to be on contrast medium, and When Dr. Errol gave me this topic, I clearly know what he wanted me to speak on. He wanted me to speak on, forget about all the other investigations, speak on an ultrasound, right? Because that's his passion. Anyway, so let's go ahead and see contrast medium use in ER. I'm sure all of you sitting here and all of us sitting here use a lot of contrast every day in and day out. Before we go on to the main talk, let's slightly understand what is this contrast medium, what does it actually mean. Contrast mediums, and then the use of contrast mediums in an emergency department, and then let's see what are the risks involved by using contrast mediums in an emergency department, some of the complications associated with contrast mediums, and how do you mitigate those complications. This is going to be our agenda for today. Right, so what is a contrast medium? The first sentence or the definition of a contrast medium is very important for us to understand. These are used to supplement the capabilities of various imaging modalities. Whenever we use this word supplement, that always means there is an alternative available. So this is very important for us to understand that whenever possible, try to avoid a supplement which is a contrast. I'll tell you why in the forthcoming slides. Basically, there is oral contrast, IV contrast. For the sake of today's presentation, we will only stick to IV contrast. These contrasts are basically iodine based. They could be ionic and non-ionic, either high, low or iso-osmolar. This osmolarity is very important because most of the trouble because of this contrast medium is because of the osmolarity. So we will come to that later in our forthcoming slides. And the recent ones, we use a lot of non-ionic, iso or low osmolar. These are the recent contrast mediums which we use to reduce complications. And MRI scans, there was a question to the previous speaker on MRI use. They're currently with MRI we use a lot of gadolinium based contrast. So this helps in reducing the complications associated with the contrast medium. Right. So what are the indications of use of contrast? There is a lot of controversies in use of contrast medium, whether we should use contrast in an emergency department or whether we should pick up a different kind of imaging modality or a higher imaging modality. There are a lot of papers supporting and opposing. So usually we prefer IV and oral in abdominal CT. In case of an uncomplicated appendicitis, diverticulosis, nephrolithiasis, mesenteric ischemia, portal vein thrombosis, any brain CAs, bowel obstructions, and these are some of the indications which we use contrast media in emergency department, which most of us know. And for contrast in CT, brain basically to delineate tumors, CVT, carotid and vertebral artery dissections, and any aneurysmal bleeds. And there are contrast enhanced ultrasonographies. I'm not sure how many of you still use it. This is basically used for solenoid injuries, bleeding hematomas, and abdominal aortic aneurysms. So these are some of the common indications which we use contrast in an emergency department. But there are a lot of controversies surrounding it, whether we should be really using a contrast medium to diagnose all this, or shall we use a simpler medium like in say an ultrasound, or whether you should go for an MRI. So, but that's not the context of our study. What is the problem of using a contrast medium in an emergency department? What are we worried about? Basically, when you look at an emergency department, what are the types of patients who walk in? This is a new patient who walks into your emergency department. Basically, he needs a radiological investigation with a contrast. You have no idea about this patient before. You want to assess whether is it risk for him to develop any kind of a reaction to the contrast. So basically, you do a risk assessment for some. If somebody falls into the risk category, you need to decide what are the types of investigations you're going to do before you subject him to any kind of a contrast exposure. This is two. You will also have a set of patients who will come and tell you they have had an history of allergic reactions or complications to contrast before, but unfortunately you still have to do a contrast for them for various reasons. So this is the third group. So you've got a new patient who's coming, you've got to assess whether is he risky, is he in a risk group for developing any kind of an issues. You have a group which comes in and says, yes, I have a problem with contrast media before, but unfortunately we need to do a scan for him. And the third group is clearly somebody who has got high risk. So I'll talk about that a little later. So what is the problem with the contrast medium whenever we're talking about? Any contrast medium, we basically talk about only two things. One is a hypersensitivity to the contrast itself, which is very difficult to predict. And then everybody knows there is a renal injury which is associated with any contrast medium. The renal injury could be acute or this could be delayed. So let's talk about that a little more. And there are some non-renal complications, some of the important complications which we will talk about, but as I told you, these are iodine based. So whenever I talk about iodine, clearly there is a thyroid involvement here as well. So let's talk about that a little more in detail. Right. Who are these patients at risk? In other terms, who who are the patients who walk into an emergency department who really need a creatinine levels before going in for a CT? So this is a common practice where we keep them all waiting to get their creatinine levels before you subject them for CT. Right? But do really everybody need a creatinine level before you subject them for a CT scan? That's what we need to think about. Right? Who are those people who are really at risk? That's where the history is very, very important. Anybody gives you a previous history of allergy, not just to allergy to contrast medium, but anybody who has got more allergy-prone tendency, frequently comes in with an allergy for anything, be it for a footstep, be it for hay fever, for example, they are at high risk for developing contrast allergy as well. Anybody who has got an atopic tendency. Somebody who is severely dehydrated, they are more prone for renal injury, so you need to hydrate them well. Extremes of age, somebody who is less than 5 years of old or more than 60 years are clearly at high-risk group, so clearly these are the populations where you need to screen their creats. Somebody who has got a serious illness on chronic debilitating, any kind of nephropathies, diabetic nephropathy for example, these are the people who are at very high risk. Those with anemia, anybody with co-medications, for example metformin, which usually impairs your renal excretion, and anybody with malignancies. Typically this is your high-risk group, and this is exactly what you need to elicit from the history to see whether this patient needs a creat or not. A young healthy patient, say a 25-33-year-old, walks into the emergency department, you want to do a contrast for him, he doesn't fall into the risk group, do you really have to keep him waiting for a creat? That's a big question mark. There is no indications for him to actually get a creatinine before you subject him for a contrast CT. All you have to do is take some precautions. Right. So who are those people who are going to get creatinine in pre-screening? These are the indications clearly. Those who have got history of anatomical variations in the kidney, like horseshoe kidney. Those who have undergone renal surgeries before. Those who are in renal endangering medications, like be it NSAIDs. Those who are nephropathy prior, like diabetic nephropathy, hypertensive nephropathy. Those who are in prior renal dialysis or malignancies, nephropathy-associated chronic diseases, and drug interfering with renal excretions like metformin. So these are the people clearly you have to get a creatinine levels before you subject them for a contrast exposure. Right. Alright, so here is a patient who needs an urgent CT. He has got a known history of allergic reactions. Right. We're talking about adult patients here, not pediatrics. What is the best way to manage a contrast reaction? The best way is to avoid contrast in the first place. Look at an alternative options if available, either an MRI or an ultrasound scan which can give you an equal sensitivity and specificity on those diagnoses. Try to prefer that. Try to avoid contrast medium. But unfortunately, if you cannot, these are the medications which you will prefer before subjecting them for CT scan. Before subjecting them for contrast exposure, be it MRI or CT, where usually you give steroids, hydrocortisone 50 mg IV every 4th hour until the procedure is complete, plus diphenhydramine 50 mg per oral or 25 mg IV 1 hour prior to the procedure. If allergy or contraindication to steroids, it's still possible because these are the people who have atopic tendencies. Pre-medicate with diphenhydramine 50 mg per oral or 25 mg IV 30 to 60 minutes prior to the procedure. So these are the people who needs pre-medication before subjected to CT. Right? What is the problem with contrast media? Why are we worried about renal injuries? What is the mechanism behind this renal injury? What is the problem statement? This is the osmolarity, as I briefed you some time back. There is an ionized contrast media was postulated to cause this extracellular fluid shift in the renal cells, leading to the cell dehydration, and there is increased intracellular fluid viscosity, which precipitates the cellular dysfunction. This is exactly the mechanism behind renal injuries in use of contrast. So, because of the high osmolarity of the contrast medium. So how do we mitigate this? So ensure that the patient is well hydrated. I'm not talking about somebody who's already in a renal failure. This is about a normal patient who's at high risk group. Clearly make sure you hydrate them well, the urine output is adequate. And you can also give them soda bicarb infusion. I know there's a lot of practice of giving soda bicarb, NAC, theophylline, statins, diuretics to mitigate this. Clearly there is no studies which shows benefit over each other. As long as you hydrate the patient well and maintain good adequate urine output, you don't require any of the other agents like soda bicarb or NAC to prevent renal injuries. Right? So when you come to the non-renal injuries, so what are the possible complications you might get? You might get mild, moderate and severe symptoms. Like mild symptoms might range anywhere from anxiety, chills, cough, dizziness, flushing, headache, itching, nasal stuffiness. The moderate symptoms, the bronchospasm, wheezing, hypotension, dyspnea, laryngeal edema, severe anaphylaxis. And the severe symptoms includes convulsion, arrhythmias, and profound laryngeal edema as well. So how do you manage any mild symptoms which originate with the use of contrast media. Clearly, you use diphenhydramine, 25 milligrams, either as per oral, IM or IV route, and you may repeat or increase the dose up to 50 milligram. And hydrocortisone steroids, usually 100 milligrams IV push over a minute, and adrenaline in case you think the patient is landing up in severe anaphylaxis and IM. That's a standard treatment for any anaphylaxis as such. Right. If it's a moderate symptoms, remember the patient might exhibit both sympathetic as well as parasympathetic symptoms as well. If there's a vagal involvement, clearly the patient might show bradycardia. So in these patients, you actually require atropine. And anybody with hypotension and tachycardia, so clearly it's an anaphylactic kind of reaction. So put them on adrenaline IM. And anybody with a respiratory distress, clearly beta-2 agonist, and as well as anybody can even develop seizures, so lorazepam is the standard treatment of choice. So there is a possibility of rebound for any of these patients to develop allergic or atopic reactions after the use of contrast media. Usually happens about 6 to 12 hours later. So how do you mitigate that? Usually you use steroids, either hydrocortisone or methylprednisolone, 50 milligram 1 to 2 minutes every 6 hours, or methylprednisolone 40 milligram every 1 to 2 minutes for next 6 hours. So this is how we prevent rebound. So what are the renal immediate injuries, which is contrast-induced acute kidney injury? We call it as the recent terminology CIAKA. So this is abrupt deterioration in kidney function manifested by an increase in serum creatinine level with or without a reduced urine output. So it clearly states that you don't have to have a reduced urine output. Your creatinine levels is a single identification factor for the involvement of kidney damage in case of a contrast. And any contrast which is used intra-arteriously clearly has got more risk when compared to an intravenous contrast to develop renal injuries or acute kidney injuries. Right, so how do you measure that? So there's a diagnostic criteria for contrast media induced acute kidney injury. When the absolute serum creatinine increase is greater than or equal to 3 milligram per deciliter, it's clearly because of the contrast, and increasing the percentage of creatinine before and after the study is more than 50%, clearly this is because of the contrast. And if the urine output reduced to less than or equal to 0.5 ml per kg for at least 6 hours, you can think about contrast-induced acute kidney injury. And as I briefed you earlier, clearly urine output is not a clear indicator for contrast-induced nephropathy. Always think about the first, which is in creatinine. So always a creatinine value more than 3 or more than 50% increase from the previous value. If you could remember these two, that would be great. Right. So there are certain delayed renal complications as well, which not many of us think about or deal with this as this is beyond the scope of EM. Clearly there is a nephrogenic systemic fibrosis which happens, especially with gadolinium-based scans. Right? This is extremely fatal, and the most complicated issue in this is you cannot identify it through any of the scans or any of the investigations. So clearly these are the patients who undergo contrast scans, and after 2 or 3 days or about 4 days, you clearly see them deteriorating and in a cardiac arrest, and you are sometimes attributing that to the primary illness, but there is a reason, which is nephrogenic systemic fibrosis, which is a result of a contrast-induced nephropathy, so which might kill the patient as well. So you may think about this condition. Not many of these come across regularly. So when I talk about delayed complications of a contrast media, there are clearly non-renal complications, because most of your renal complications are immediate. It will manifest within 6 hours. And there are some delayed complications like thyroid complications, which may happen to 1 week post use of contrast. Iodine-provoked thyroid functions, disrupt auto-regulation, so hyperthyroid kind of symptoms, high risk of hyperthyroid status patients. So that we need to understand. So in general, our take-home message is, how do you have safe renal practices? Anybody with patients with a serum creatinine more than 2 grams is clearly at risk. Try to look at an alternate treatment modality for these patients. Ensure that they get adequately hydrated before you put them onto the contrast. So anybody who has got a creatinine borderline, hydrate them. Even before hydrating them, think about any alternative modalities, and if you cannot, then you subject them for contrast medium. Don't put them on contrast directly. Somebody who has got a renal disease, but you still produce urine, consider alternative. Do not put them on contrast directly. If you don't have any other alternative, use the lowest possible dose of contrast as possible. Use intermediate or low or smaller and or low risk gadolinium-based contrast media. And clearly nowadays there is non-ionic and low or smaller contrast mediums available. So your radiologist will suggest you that. So try to use those, and that's followed by a prompt dialysis. In case if the patient is already an end-stage renal disease patient who makes no urine on a full-time dialysis, you really don't have to worry because there's no renal tissue for you to damage further. So you can think about using the full dose levels of contrast. So these are the three. So this is my take-home message for today, and I'm happy to take any questions. Thank you.
Thank you, Dr. Saravana, for this excellent speech. I will take your questions for you because he will leave early today. And is there any question for this topic? Or any input? No question. Thank you.
Thank you so
very
much.
much. Have a nice day. Now, as a third speaker, I want to introduce Dr. Mustafa Kesapni from Antalya Research and Training Hospital, and he will talk about the perspectives of abdominal contrast tomography.
Good morning, everyone. My name is Mustafa Kesapni, living and working in Antalya City Center, Training and Research Hospital. My speech is about abdominality, the personal pitfalls and advantage and disadvantage. Also, I want to speak about why we are using. I will give you some epidemiological features of the CT and what is the indications, advantage and disadvantage, my objectives, and end of the presentation I will speak about the future of the abdominal CT and some of the special groups I want to explain to you today. And there are some numbers on the presentation, as you see that approximately 20 years, the CT or total CT is growing almost 10 times, but at this period, for 20 years, just the patient flow is approximately 5 times is growing. So that's why we are using abdominal CT in our department so spread. And in Turkey, just 11 million people, 11 million CT scan in all of our hospitals we are using also in Turkey. These of them, the CTs, when you look to the abdominal CT is 10 times more, according to the others. The other is thorax CT is 5 times much more. And 25% CT is, we are evaluating our emergency department. So we are using spread also. And there was a meta-analysis also here. We are using approximately for adult people 17% around of, for children 5% around of, and for the older people almost 1 over the 4 people. For older people we are using CT in any way. That was huge numbers also. And which indications we are using, especially first of all lower quadrant pain. First of all, the second one is flank pain. The third one is abdominal, non-specific abdominal pain, and the fourth one, we are using left side of the abdominal pain. We are using in our departments, my friends. Why is the increasing of the CT? Because CT is available everywhere, in almost resuscitation room. When you go to any hospital in Turkey, in all of the world, machine was so spread, machine was so located, all of the hospitals almost. And in Turkey, for example, if you are working outside of the city centers, you can find easily much more than ultrasound or the other modalities. I mean, you are taking to the CT, you are sending with telemedicine Ankara or Istanbul center. There was a radiologist on the table and he getting the comments, sent you to back 1 hour, 2 hours later. It's so easy for the clinician, so especially general practitioner in our rural area in Turkey. So we are reaching to the CTs much more easy to other modalities. And then another one is for Turkey, for example. We are so crowded emergency departments. We are so many patients flow we have. So we are getting to we are afraid of all of us, afraid of the malpractice. So sometimes we have to make defensive medical decisions. And we have also some procedural advantage. We have what was it on it? First of all, non-dependent to the person, the same as ultrasound, and the second one, abdominal gases or adipose tissue, sometimes not connected to image quality. And especially in trauma patients, we have visualization of the retroperitoneal area, so excellent. So some of the new technologies is improve our image quality. Multiplanar reconstruction also transfers sagittal coronal and multi-vector machines available all over the world. So as on the picture, as you see, we are using, and especially life-threatening indications, we are using these modalities. I mean, abdominal aortic aneurysm, thoracoabdominal dissection, intraabdominal hemorrhagia, penetrant abdominal trauma, mesenteric ischemia, blah, blah, blah. And then the others, mostly, especially in children, for diagnosis, for differential diagnosis, appendicitis, renal stones, especially adult people, hernia, we are using these indications of the abdominal CT on ED. American College of Radiology suggested that 4 different variations of the abdominal CT using in ED. First of all, one of them is abdominal pain plus fever, abdominal pain plus fever plus no surgery or yes surgery, and the other one, abdominal pain or plus neutropenia. All of them is appropriate modalities of the evaluation, it says to the American College of Radiology. And also, maybe the most important one is the fourth variant, non-localized abdominal pain, and none other, any specialty. I mean, most of the people, same as like this position, and it suggests to us CT abdominal pelvis with IV contrast, usually appropriate. CT abdominal pelvis without IV contrast, usually appropriate also, and also suggests to us MRI modalities. And also, my friends, how was diagnostic efficiency? Why we love so much abdominal CT for evaluation of our people? Because it changed our management of the patients. I mean, approximately 50% to admitting rates to changing our diagnosis. So we are loving. You see some of the papers here, approximately 50% changing to the diagnosis, 25% changing to the surgical plans. Also, there was a review article. Also, you saw that there was a change modalities. Also, you see that here at this column, you saw that almost 40% to 60% changing our management of the patients. So we are using so much, so we are loving abdominal CT in our departments. And also, we are using penetrant abdominal trauma. Also, it says to us, FAST plus selective cases of the abdominal CT is gold standard also. Especially trauma people, it suggests to us also gold standard. Also from Turkey, a paper, CT guided tractography also, we evaluate some of the penetrant abdominal trauma, much more easy, much more excellent type of the management. And on the summary of the abdominal CT, it provides more accurate diagnosis to us, cost effective, non-personal dependent, fast, and most of the gold standard modality. And then what was the disadvantage of the abdominal CT? First, radiation exposure. Approximately 10 millisievert, according to your machines, approximately 10 millisievert radiation exposure is one of after the one of abdominal CT. I am speaking about the adult people and speak later on children. And then 10 millisievert, what it means, I will try to explain to you. And if you get 100 millisievert effective radiation dose, 100,000 people, one of them is getting triggering to the solid cancer. So, especially if you are using on brain, you are approximately, especially in children, 2 or 3 times leukemia and glioblastoma, you are triggering also. So, for example, in 1945, after the Second World War, who survived to Japan, they get approximately 50 or 60 millisievert who survived. So, if you get 5 or 6 abdominal CT on your life, you are getting to your survival of the Second World War equal to your radiation exposure. Also, this picture is, I think, maybe on your brain today because of risk is almost small. As you see here, we speak about 10 millisievert, but after around of 0.2 to 0.3, around of the percent, we coming to the malignancy of the abdominal CT. But if you are getting 100 and maybe 150 millisievert radiations, you are getting to the much more radiation also, my friend. And let me continue. Some of the mechanisms, some of the recommendations to reduce to the effect of the radiation, that's mostly speaking on it, to reduce to the dose of CT. I mean, most of the CT machine is using 120 kilowatt energy level of the radiation. So if you reduce this energy 100 or maybe it's 80, it will be much less radiation exposure to the people. So some of the papers, for example, they reduced to the level of the energy 120 to the 100 approximately radiation dose half, almost 5.7. So when you look at the pictures, one of them is the left side of them, there was a older people. The right one, left one is the 120, the other one 100. As you see that there is almost same image quality. And the other one is the right side of you. There was acute appendicitis in young people. So image quality doesn't change, and also statistically it doesn't change more. And another paper here, it's about the cancer people. They reduced the energy level of the 80 kilowatt of the radiation exposure. Also, there is no any differences, any bad quality of the image. They didn't provide it. So, especially in children, reduce those appendicitis. There is a sensitivity and specificity also high. So, median dose of the reduced dose was approximately 2 millisievert. That was excellent. Because we are in nature, we are just 3 millisievert radiation we are taking every year, all our natural environment. So this is 1.8 is so rare, so little point of the radiation exposure. And some of the another mechanism, for example, some of the researchers bringing together ALARA as well as reasonably achievable methods, they are reducing all of the radiation exposure. So if you use this kind of methodological approach to patients, approximately 70%, 65% radiation exposure you are reducing. So another one is multidisciplinary European low dose initiative strategic research agenda for low dose radiation risk research. They are European countries collecting together and they are trying to reduce to the energy level of the machines for CT machines. And the other one, we have to use contrast or non-contrast. Before the speaker, to me, little bit focused on these topics, and we have to do, first of all, there is no need to use oral contrast, my friend, in ED. So we are using the vascular abnormalities especially, and infectious abscess. We are using but allergic reaction and contrast nephropathy, we are seeing our patients. And as you see here on the second references, the elimination of oral contrast did not lead to any misdiagnosis because time consuming, you see here, there was a colitis people. On the left picture, there is no oral contrast, and the right one is the oral contrast. There was no image quality different each other. So there was a meta-analysis, also review article, sorry. As you see here, on 2014, there was around of almost 3,000 people. Just one people changed. They didn't use the oral contrast, so there is no need to use oral contrast. Also, when you use oral contrast, your patient stay after the emergency department is so long time because you need more time. Nephrotoxicity is another trouble for the abdominal CT. If you are normal people before your renal, you have no renal failure, your risk is maybe 10%. But if you are renal impairment before, your risk is go up 30% around of. I found on the literature there was a meta-analysis on American College of Emergency, Annals of Emergency Medicine last year. There was around of 28 papers they collected. And around of 100,000, more than 100,000 people, they meta-analyzed, and there is no risk, there is no any difference between to use oral contrast, to use contrast or non-contrast CT. So maybe, but this is a little bit confusion topics. I will not speak more on it. And also, one of them is the other disadvantage of the CT, incidentoloma. You are getting abdominal CT or anywhere. You are finding any findings, mass, anything, abnormalities like this. So we defined that incidentoloma, approximately 80%, 85%, these findings, incidental findings is benign, but your plan is changing. I mean, maybe 10%, 11% your patient, management of your patient is changing. So that was another trouble for abdominal CTs, my friend. And also, it's the same as with the children. It's not just adult people. You are finding in children also maybe 30% around of the you are finding. But children's lesion is much more benign also, my friend. Also, I want to speak a little bit special ages group for pediatric people. It's changing to the using, for example, in Japan, they are using 3%, in USA, 11%. In Turkey, I don't know the exact number. So, most of them is trunk, but it's cranium and the trunk also abdomen. Why is the radiation is sensitive for the children? Because their life of expectancy is so high. So if you meet to the early of their life with the radiation, they are getting to the proliferating cell is affecting their sensitivity of the radiation is affected their more dividing proliferative cells. So becoming solid cancers also, my friend. And also especially teenager group, ladies, for girls, their throat and their breast tissue is so sensitive for radiation exposure. So there was another paper declares here, a single radiation exposure in 1-year-old child to be 1 in 550 following an abdominal CT and 1 in 1,500 following a brain CT. And it's a huge number also. But I will show you another presentation. Also, this picture shows to us if you meet on your life, in the beginning of your life, your risk is so much. For female, and female is more sensitive according to the man's also, my friend. Another topic, we are using especially, they look to the especially trauma center. If you are a children, you go to the children's hospital, and the children, you go there, general hospital. And the second hand, you go to the pediatric hospital or pediatric trauma center. In general hospital, approximately 4.5 times, the radiation is, they are using to use the much more eager to use the CT. So they are using the less abdominal CT. So also trauma centers, as you see here, these papers show to us general hospital or non-academic hospitals or non-trauma centers provide more radiation to our children. So it's a little bit maybe attention at this point also, in my opinion. So what about geriatric people? Geriatric people is almost our maybe 20-25% nowadays our patients. So their complaint is chest pain, shortness of breath, and then third one is abdominal pain. And their abdominal pain is management is so difficult sometimes, not the same as younger people. So they are changing their admitted rate is high, their surgical operation rate is high. So their mortality is also after the 8 years, they almost go to the 40%, 50%. So we have to use also gold standard for geriatric people. Pregnancy doesn't recommend the guidelines any using to the CT, but there was just one paper I bring to you. It says to us, perform MRI. If you doesn't find, you can use it, but there is no any recommendation, much more recommendation. Also one paper, they used the reduced dose of the abdominal CT for pregnant people. It doesn't suggest, but if you doesn't find the MRI, you can use the safe class, short class, but this is just one research also. We cannot say that this is general rules. And end of my topic, I just want to give to you new things. Do you have any idea artificial intelligence? As you know, we are using, especially last year, it was using artificial intelligence of interpretation of the CTs and MRI findings. So, as you see here, every year in 2015, 2016, 2017, almost every year 30% this paper is growing up. So machine learning, big data, automated report generation, multimodality image analyzers, publicly available data sets and competitive challenges is coming up to us. Maybe two Congress later, we will speak, we will compare to which one is to be radiologist or artificial intelligence, which maybe we will speak about on it. I will show you another papers about on it. and also progress in fully automated abdominal CT interpretation, and the sensitivity, specificity is so high, my friend. I will show you also. And these are World Journal of Gastroenterology. They focus just liver of the finding. They comment to the artificial intelligence, comment to the liver pathologies, and otherwise the radiologist make comments. So there was equal each other. And last topics about these topics, and future of artificial intelligence for abdominal CT, there was almost acute findings they detect, and also same as autopilots in the aircraft, same as auto drivers in our cars, and same as, but the comment all to the people now, maybe in the future we will speak much more difference. And summary of my presentation is management of patients. We have to use universal algorithms, good medical practice. Under the MRI presentation from our guest from Saudi Arabia showed good pictures. One of the man is footing two chair more before history, no physical examination, no laboratory. It goes to the directly CT or MRI. Same as we have to do our job is good medical practice. No amount of radiation should be considered absolutely safe. And special age group needs more attention, especially in children. You have to be pleased to think twice, and then some emergency situation, some life-threatening situation, because we are ER docs, so higher benefits than harm in ED, especially life-threatening conditions we have to be aware of. Thank you very much for your attention.
Thank you for this presentation, Dr. Kesap. I will take questions after the end of panel for you, because we have a little bit delayed. Now the next speaker is me. It's myself. Yes. Good morning again. And we have changed the program a little bit because some of the speakers should go earlier than expected. So I take the last presentation last rank. I am professor of emergency medicine, and my name is Erol Ünler. Most of them know me, but I will briefly introduce myself. In order to not know me very well, I am one of the board member of the İBET Society, Emergency Physician Association of Turkey, and I am working with the Basar Cander, and I am the president of Sonos School International Network, also the head of the imaging section of İBET Society. And today's topic is stethoscope or ultrasound. Most of you know me as an ultrasound face of the Turkey, and nationally and internationally. And I will discuss which is better in this presentation. And my lecture wrote like that. First we will begin with the history, and after that we will go with the physical examination, which is composed of inspection, percussion, palpation, and the use of sound waves, either by your ear or by your eye. And we will go over with the diagnosis and management, and at the end we will see the result of our patients. These steps totally represent our clinical practice. This is the standard of medicine. And we are starting from the history. And you know this Chiron. Chiron is the teacher of the several pupils, several students, including Apollo. Apollo was the father of healing, was the initiator of healing, and in Greek mythology. And don't be scared, because I will not talk about the history so long. I will pass very quick. And also, the Asclepion was one of the pupils of Chiron. And it is called the god of the medicine, father of the medicine in the Greek mythology. And after that, after this guy, we see the Imhotep. Imhotep comes from the Egyptian land and was one of the first doctors in the Egyptian countries. He was also an architecture and also a doctor. And this is the Lachman physician from Anatolian land, from our land. And now we came to real history. Real history begins with Kos Island and also the Aegean part of the Turkey. Hippocrates comes from the Kos Island, and the Galenus comes from the Aegean part of the Turkey. These two guys are very important for the medical practice, because the Hippocrates was used to do external inspection. This is the first step of physical examination. And he was the father of external inspection. And the Galenus actually was the father of internal inspection. I think this is the first declaration of this terminology, internal inspection, because the Galenus did the first dissection of animals to see the internal organs. Okay? So now we have two historical pathways, one of them for external inspection and the other for internal inspection of the anatomical organs. And we see the Umbrager for investing the percussion in the physical examination steps. And now we see the Laennec. We should send our salutes to the Laennec, who is the inventor of the modern stethoscope in the medical history. And also, on the internal inspection pathway, we see a very important doctor, William Harvey, who did the first anatomical dissection of human body, not animal, human body. So internal inspection actually begins after Galenus with William Harvey. Now, we are here with our modern stethoscopes, modern ultrasound machines, and also we should remember this doctor, Dr. Donald. In the history, he was the first performer of ultrasound for a pregnant patient in the diagnostic medicine. So I'm very appreciative for this guy. And after the history, we see that we are the champion. We are the specialization group who use ultrasound most frequently in the emergency department, in the critical care patient. I didn't say like that. The literature says like that, because most of us use ultrasound in unstable patients over than 95%. And we are the champions. And we feel very strong and very confident among the other physicians, internal medicine, critical care physicians, and among other specialists. And when we look at the timeline of the ultrasound in the history, we see the first published scientific literatures in the era of trauma come from the focused assessment of sonography of trauma. in the early 1990s. And when we look at the timeline from the beginning up to now, the steps of ultrasound in the emergency department, we see that it begins from 1970s and ends up to now. And they built a lot of guidelines, a lot of pathways, fast protocols, fast protocols, false protocols, fake protocols, ACEs, rush protocols, a lot of protocols. And I cannot pass this slide without mentioning Sono School, because I am the president of Sono School, and I should advertise it. I have only conflict of interest with Sono School and IPED Society. And what this picture